All right, so let's start. Hello, my name is Sidrah Fathima. I'm a third-year medical student, and along with Tasneem, I'm going to be explaining the CVP physiology practice sessions. So I'll be going over questions, and I'll give you some time to go over it and come up with the answer. Then I will show you the answer, and then I will try to explain it to you. So let's get started. Okay. So the first question is this. In the sinoatrial node or the SA node, phase 4 depolarization or the pacemaker potential is attributable to, you guys can like write the answer in the chat and what you guys think is the answer. Would anybody like to answer or write in the chat? If not, that's fine. Then I'll just go over the answer. Oh, okay, we got something. B, okay. Anyone else? Okay. All right. I'm getting B's. And so the answer is B. Great. Good job, guys. And so the reason why it's B is because if we look at the phase 4 action potential, so in an SA node, we know that the depolarization phase is usually due to the L-type calcium channels. Right, so over here, we have the L-type calcium channels, which open up, which cause this depolarization. And then at this peak over here, we have the potassium channels that open up, and therefore we have deep repolarization, where the membrane potential becomes more negative until it reaches this point over here, where the funny channels open up. And the funny channels allow for sodium to come into the cell, making the membrane potential more positive. And that's why phase 4 is mostly due to the sodium channel influx. Okay, let's go on to the next question. During which phase of the ventricular action potential is the membrane potential closer to the potassium equilibrium potential? So what do you guys think? Okay. All right, you guys are doing great. It is actually E, which is phase 4. And why is that? Because the potassium equilibrium potential is usually around negative 90 millivolts. And here we can see at phase 4, it's around negative 90, which is close to the potassium equilibrium potential. So great job, guys. Moving on to the next question. During which phase of the ventricular action potential is the conductance to calcium the highest? Great job, guys. You guys are amazing. Yes, it is phase 2 or C. And phase 2 is the plateau phase in the action potential, which is basically where we have potassium efflux. So we have this here. So we have potassium going outside of the cell, but here we have the L-type calcium channels that open up. And so we have calcium influx that happens as well. So therefore, this membrane potential over here is both positive and negative. So it's kind of an equilibrium phase, which is why we have this plateau phase. So yes, phase 2 is due to calcium influx. Moving on to the next question. Which phase of the ventricular action potential coincides with diastole? All right, so I'm seeing a mix of answers. I saw E and I also saw D. Now, the correct answer is E, but I'll explain why it is E and not D. Because when we talk about diastole, it's when the ventricular myocytes are relaxed. And in D, in E or phase 4, we're at the resting membrane potential. Here, the ventricular myocytes are completely relaxed, meaning there is no contraction happening. Whereas in phase 3, it's in the repolarization phase, so it's at the end part of the action potential. However, the ventricular myocytes are not completely relaxed, and therefore it's not ventricular diastole. So it's phase 4, that's the right answer. Moving on to the next. So basically this slide is from your lecture, and it basically explains each part of the ventricular action potential. And like I mentioned, in phase 0, we have the increase in sodium. So we have the depolarization part. At phase 1, we have the opening of the potassium channels, which lead to the repolarization, which the membrane potential becomes more negative. And then in phase 2, calcium channels open, so we're at a plateau phase. Then we get to phase 3, where the calcium channels start to close, and we still have the potassium channels open. So we're at, it starts to become more repolarized and more negative. And it starts to go down to the resting membrane potential. Phase 4 is where there's ventricular diastole, and the ventricular myocyte is relaxed. Moving on, which of the following statements about cardiac muscle is most accurate? Yes, great job, guys. It is B. And that's because we need calcium for the contraction of the cardiac muscles. So yes, you guys are correct. The next question. A 38-year-old woman has a bout of intestinal flu with vomiting and diarrhea for several days. Although she is feeling better, when she stands up quickly, she feels faint and lightheaded. Well, someone asked, why was C wrong? So for the previous question, this one, I'm assuming it's this one. C, it says, on top. C says, in cardiac muscle, the initiation of action potential causes an immediate opening of slow calcium channels. So the reason why this is wrong is because when we saw the action potential, it wasn't due to immediate opening of slow calcium channels. It happens over time. There's a delay between the depolarization and the opening of the calcium channels. So the wording of this answer choice is wrong. It shouldn't be immediate opening. It's a delayed opening. Is that clear? All right, you're welcome. Okay, so for this question, a 38-year-old has a bout of intestinal flu with vomiting and diarrhea for several days. Although she is feeling better, when she stands up quickly, she feels faint and lightheaded. Which of the following explains why she is feeling lightheaded? Also, if you guys think I'm going too quick, please let me know. And if you have any questions, just ask in the chat. All right. A lot of you said A, which is the correct answer. And why is this? Because when we have intestinal flu or we are vomiting and we have diarrhea, we're losing a lot of body fluids. So that decreases the blood volume. And if there's a decrease in blood volume, naturally there's a decrease in preload. There's a decrease of blood that is going to the heart and filling up the ventricles. And because of that, we also have a decrease in cardiac output. Moving on to the next question. Which of the following is correct about ECG? Okay, so I'm seeing B's, but I also saw a C. The correct answer is C, but I'll explain. So here we see the wave segment, the whole ECG, right? Um, People said B, which is if I remember correctly, it was the P wave, which represents the contraction, the depolarization and repolarization. But actually, the P wave represents the depolarization only. It's not the repolarization. So P would be the P wave would not represent both, and therefore B would be incorrect. But C is correct because the PR segment is the QT interval. Sorry, that's what C stood for. The QT interval is basically the time that it takes from the beginning of ventricular depolarization to the end of ventricular repolarization, which is the whole time for systole. So here we have atrial. Here we have atrial depolarization, and then we have we have atrial depolarization. And then the PR segment here is the time it takes for the depolarization to go throughout, the delay basically, where the depolarization goes throughout the bundle of His and so on and so forth. Then we have the QRS segment, which is basically, or the QRS wave, which is basically the ventricular depolarization. And then this QT interval, which is the time between the QRS depolarization and this T wave, which is the QRS repolarization. So this QT interval basically indicates the time it takes for the ventricle to contract or ventricular systole. I hope that's clear. Moving on to the next part. When recording the lead 2 on an ECG, the right arm is on the negative electrode and the positive electrode is on the okay, this one you said, you know A is wrong, but what does it mean? So when we talk about depolarization, it's from negative to positive. Usually depolarization is negative to positive, right? But here, the mean vector depolarization is not from front to back. It's just saying that the mean vector depolarization moves from negative to positive, which is not really correct in the ECG because sometimes it can move in the opposite direction when you're having a negative dip in the ECG. So I hope that helps. I hope that helps. Okay, so the next question is this. When recording the lead 2 on the ECG, the right arm is in the negative electrode and the positive electrode is in the, yes. The answer is B, the left leg. And so here is basically the standard limb leads. We have lead 1, lead 2, and lead 3. And for your exam, you have to know the placements of these leads, where the positive electrode is and the negative electrode is. So here, lead 1, the positive electrode is on the left arm, and then the negative one is on the right arm. And again, lead 2 in our case was the left leg and the right arm. And lead 3 is the left leg and the left arm. So just keep this in mind when you're studying and make sure to have it in your head so that if you have a question like this, you'll be able to answer it. Okay, moving on to the next question. A 58-year-old woman complains of a shortness of breath on exertion. On ECG, an ECG is ordered and her lead 1 trace is shown. Which of the following waves, segments, or intervals on her ECG trace is outside of the normal range? Okay, so a lot of people said B, and that's true. And why is that? So when we look at the P wave is usually 120 milliseconds, and it's usually less than 3 boxes. Hold up. So if we zoom in and we count how many boxes is in the P wave, it's less than 3 boxes. In this case, it's like 2. So it's less than 3 boxes. So the P wave is correct. Let's skip the PR interval for now and let's go into the QRS complex. A normal QRS complex should be 0.1 seconds or between 3 small boxes. And if you count here, it's around around 2 boxes, maybe a little bit more than 2. So this QRS complex is correct. Now, when we look at, say, the ST segment, the ST segment is from here all the way from here. Wait, hold on. From here all the way to here, and it should be between 2 to 3 small boxes. And here you can see it's around 3 small boxes, so it's okay. And then the QT interval, which is from Q to T, here is the QT interval. It should be around 9 to 11 boxes. And if we count, it's like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's around 10 boxes, so the QT interval is okay. The only thing elongated here is the PR interval, which should be between 3 to 5 small boxes. So if we look here, this is the PR interval. It's 1, 2, 3, 4, 5, 6, 7. 7 boxes. So it's greater than 3 to 5 small boxes, and therefore it's elongated. Okay, moving on. A 60-year-old woman has the following EKG recorded at a local emergency room following an automobile accident. Her weight was 70 kgs and her aortic blood pressure was 140/80. What is the mean electrical axis calculated from the standard leads 1, 2, and 3 shown in her EKG? This one might take a little time, and it's okay. I'll give you a good amount of time for this because it's kind of difficult, or at least it takes a lot of work. All right, so has anyone came up with an answer for this? Okay, Ooh, great job, guys. Yes, the answer is B. It's negative 50. Um, okay. Would you like me to show you how I did it? It's, I feel like it takes a lot of time to do this, especially when we use like that drawing out method with the lines. What I like to do is just try to, in a way, try to guess, but it works for me. But basically, if we know that this is lead one, oh my gosh, there's always these lines that come up. Okay, this is lead one, this is lead two, and this is lead three, right? I'm just gonna do the opposite of these leads right here. Okay, the opposite of lead three is negative 60, and the opposite of lead two is negative 120. Okay. Now, when we look at the ECG and we see that lead one is positive, we go towards the positive end of lead one. So we're saying it's about over here, okay? And it's relatively positive, so it's somewhere here and here. And then we go to lead two. Notice how it's a little positive on this end, but also, let me use another color. It's a positive on this end, also negative on this end, but it's more negative. So I would go lead two, the negative side of lead two, somewhere over here, maybe like here. And then we're going to look at lead three. And I think lead three is the main thing that helps you to determine what the answer is. So lead three is more negative. So we go to the negative end of lead three, which is around negative 60. It's here. And it's more towards lead three because notice that lead three, the amplitude is way bigger than like lead two and lead one. So we're going closer to lead three. So looking at this, we can see it's somewhere between 0, negative 60, negative 20, but it's more towards negative 60 than anything else. And from the answer choices, we see that there's negative 90, negative 50, negative 12, positive 100, and positive 170. And the closest to negative 60, or the closest to the opposite of lead three, is negative 50, and that's the answer choice, basically. And this is like, a really bad way to determine it because like it's basically guesswork. And there is a better way to do it based on our lectures, which is this way, where you do the semi-quantitative method, where you only use the three leads that's provided. And if we were to do the semi-quantitative method on this one, say this is the opposite of lead, it's negative 120, and this is the opposite is negative 60, and this is the opposite, it's negative, is plus positive 30, and this one is positive 150. And so we basically go, lead one is positive, so we go to the positive end and we go plus like three segments, plus three segments, and then we do the same thing for lead two. So lead two is more negative, so you go to the negative end of, negative end of lead two, and you go positive three segments and negative three segments. And then again, you'd go to lead three and go to the opposite of lead three. So in this case, it would be negative 60. You go positive, negative, and you can see there the overlap is around negative 60. So you can say if it's around negative 60, then the answer should be negative 50. I hope that works. I hope these methods are helpful. If not, then my bad. I'm sorry. um, so yeah. But you guys got it right, so that's really amazing. Moving on to the next question. A 65-year-old man had the EKG shown here recorded at his annual physical examination. Which of the following is the likely diagnosis? Wow, you guys are so amazing. You guys get the answers right every single time. Yes, it is C, and it's a second degree AV block. But do you guys know which type of second degree? There's two types. There's Mobitz 1 and Mobitz 2. Which do you think? Is it Mobitz 1 or Mobitz 2? So I see type 1 and I see type 2, and I have to say that it is type 2. And the reason why it's type 2 is if you were to look at the PR intervals here, the PR interval is like this, My bad. Okay. Here the PR intervals are they're pretty regular, right? They're the same throughout. If it's Mobitz type 2, it kind of happens on a sudden. There's no elongation of this PR interval, it just randomly drops a beat. Whereas in type 1, the PR interval starts to elongate over time. So it starts like this, and then it goes like this, and then it goes like this, and then we have a drop beat, like that. So if you were to look on the next slide, this is basically it explains the different types of heart blocks. So in the first degree, the PR interval is elongating the whole time, but there's no QRS drop. So we have elongation, but no QRS drop. And it's the same type of elongation. In type 2, Mobitz 1, we have a progressive PR elongation. So it starts off normal, then it gets longer and longer, and then suddenly we have a QRS drop. In type 2, Mobitz type 2, basically, or second degree type 2, we have a normal fixed PR interval and then a random QRS drop, just randomly. Like it's all of a sudden you never expect it. And then lastly, for the third degree, it's the P waves and the QRS have no type of association. Or like you'd have two P waves and then a QRS wave, and then or a P wave without a QRS wave. And so there's no association between a P wave and a QRS wave. Okay, moving on to the next question. Which of the following ECG traces shows a regularly irregular rhythm? Oh, we have a mixed responses for this one. Interesting. I see all of the answer choices, and that's totally fine because when I first saw this, I was like, maybe it's D, but then I realized it was like A. So the answer is A. And let me explain why. And it's kind of difficult in the beginning, but I'll try to explain it in a way that makes sense. So the first one, right? We have it's irregular, you can tell. The reason why it's irregular is because there's no like the distance between the RR waves are not the same. There's like a short and a long distance between the RR waves. So we can determine that this is irregular rhythm, right? But why is it regular? It's because there's a certain pattern to it. If you look here, the distance in the beginning, let me just clear it and then use a different color. So here, let's just say the distance is kind of short, so we will say it's an S. And the distance between the second RR complexes is long. And then look at the next one, it's short. And the next one is long. So there's a pattern that's happening, short, long, short, long. And this pattern is what we'd call regular, but it's still irregular because the RR intervals are not the same throughout. Like the difference between this RR interval and this RR interval compared to this one and this one and this one is different. So we say it's regularly because of the pattern, but it's also irregular. If we look at this one, B, this is VFib, where there is no type of pattern. There's nothing that you can see. It's just a bunch of squiggly lines. So it's just completely VFib irregular. C, we would say it's irregularly irregular because you can see there's no pattern between the RRs. Like this one is like somewhat medium size, this one's long, this one's short, this one's long, this one's short, this is short. There's no pattern between them. And it's also the distances between the RR are always irregular. There's no fixed distance. These two are regularly regular, or they're regular irregular because there's a fixed length between the RR intervals, and it's a fixed pattern. Even here, there's a fixed RR interval. The length is the same throughout. And even though the ECG looks a little weird, the regularity or the rhythm is determined by the RR intervals and the length in between. So despite how strange it looks and whether there's a T wave that's inverted, like in this case, and it looks strange, you just have to look at the RR intervals and see, is it fixed throughout? And is there a pattern that you see? If there's a pattern that happens, then it's regularly irregular, as in the first case. Is change always? Yes, for rhythm, you would check the RR intervals to see how spaced out they are. Okay, so does that make sense, or do we have any other questions on this? Okay, I hope this is making sense. Going on to the next. Okay. This one's a little, I hate these ones. Okay, so a diagram showing pressure changes of the left atrium, left ventricle, and aorta during one cardiac cycle is shown. The 7 phases of the cardiac cycle are labeled on the diagram. During which phase of the cardiac cycle is the largest volume of blood pumped from the left atrium to the left ventricle? Okay, so I'm seeing C, F, and G. The correct answer is F. And I understand this is kind of confusing because it says pumped, but if you think about it, there's no pumping happening in phase 6. It's just filling of the ventricle. So let me explain each phase, and hopefully it makes sense throughout. So in phase 1, we have the atrial contraction phase. So this is when the atrium contracts and it ejects some part of the leftover blood in the atrium into the ventricle. So usually during this atrial contraction phase, around 10% of the remaining blood in the atrium goes into the ventricle. So we can't say most of the blood is in the ventricle here, it's only 10%. Then we get into phase 2. So when we say after atrial contraction, the next thing that happens is the tricuspid valve or the mitral valve closes. If we're talking about the left ventricle, it's the mitral valve. It closes, and then we have the ventricles with blood in it, and so both valves are closed. The mitral valve is closed, the aortic valve is closed, and the ventricle starts to contract. It contracts at an isovolumetric contraction. Notice here the pressure is increasing here. And the reason why is because it's trying to overcome the pressure in the aorta to make the aortic valve open, right? So we have isovolumetric contraction happening to increase the pressure. That's phase 2. Then we get into phase 3, where there is the rapid ejection phase. So at this point, the aortic valve has opened up, and now we're ejecting the blood into the aorta. So this is just the blood going into the aorta. Now we're like the volume of the blood in the ventricle is starting to go down. We get into phase 4, which is the slow ejection phase, in where there's a small amount of blood that's remaining in the ventricle that's being ejected into the aorta. So essentially in phase 3 and 4, 3 3 and 4, you're basically ejecting the blood into the aorta, and there is less volume in the ventricles. Then we get into phase 5, which is the isovolumetric relaxation phase. There's no blood going in the aorta, in the atria, or the ventricle. Basically, at this point, the aortic valve has closed. The blood is going into the systemic circulation, and the tricuspid or mitral valve, the mitral valve is closed, and so there's nothing in the ventricle. Then we get into 6, this phase. This phase, the mitral valve opens, and blood just passively fills into the ventricles. And this is mostly where all of the blood goes in. Most of the blood from the atria fills the ventricle, and this is called the rapid filling phase. So phase 6 is where most of the blood comes in. And then phase 7 is where we have the slow filling phase, which around 20% of the blood goes into the ventricle. So phase 6 is the rapid filling phase, where most of the blood flows from the atria into the ventricle. Some people said C, which was phase 3, but we said phase 3 was when it's the rapid ejection phase, where the blood is going from the ventricle into the aorta. So therefore, there's blood leaving the ventricle. Yeah, I hope that makes sense. And we can see this is also a slide that explains it all. Okay, next question. The figure represents the pressure changes in the jugular vein during a single cardiac cycle. What event produces the C wave on the jugular venous pulse waveform? Great job, everyone. It is B. It is the bulging of the tricuspid valve towards the atrium. If you look here, you can see the different phases in the jugular venous graph. And like we said, or like I'm saying right now, the A wave is the right atrial contraction. And then we have a decrease in pressure as the tricuspid valve closes and all the blood goes into the ventricle. Then, when the ventricle starts to contract in the isovolumetric contraction phase, the blood hits the tricuspid valve, which goes back into the right atrium, and therefore it forms this C wave, which increases in pressure. And then we have this X descent as there is relaxation of the atrium. The aortic valve has already opened up, so blood is going from the ventricle to the aorta, and so now the atrium is relaxed. And then at this part, this part over here, we have the right atrium is starting to fill up with more blood, and that's why the pressure is increasing again. And then here at V, the tricuspid valve opens, so we have a increase or like a little bump in it, the V wave. And then we go down to a Y descent as the atrial pressure falls because the blood is moving from the atrium to the ventricle. Okay, next question. The image shown is a left ventricular pressure volume loop. Which of the following points, M, N, O, P, correctly describes when diastole begins, when systole begins, when the aortic valve opens, when the mitral valve opens, and when the mitral valve closes, respectively? All right, so the correct answer is A. And I'll explain why. A lot of you got the correct answer, but there were a few that were not the correct, and that's okay. That's totally fine. So I'll explain why. What I like to do with these type of graphs is you try to understand what's happening by looking at the volume part and looking at the pressure part. And by looking at the distance between the 2 points and seeing what's happening in that point, you can kind of tell what's opening and what phase it is. So let's think about it from here, from the M and the P. So between M and P, we notice that the ventricular volume is increasing, but the pressure is the same. And what would happen if like the volume in the ventricle is filling, but there's no, or increasing, but there's no increase in pressure? We would say that's the rapid ventricular filling phase, or also the filling phase. And before the ventricle can start filling up, what's the first thing that needs to happen? The valve should open up, right? The mitral valve should open up. So we can say that M here is the mitral valve opening up so that the ventricle can start filling up with blood. So we see an increase in volume as the ventricle starts to open, as it starts to fill up with blood. Then we get to point P, and we notice that from point P to N, there is an increase in pressure, but the volume is the same. So here we would call it isovolumetric contraction, right? Because the volume is the same, so isovolumetric, but the pressure is increasing, so contraction. So we would say at this point P, there's ventricular systole. That's what it says here. Systole begins at point P. Then, because of the isovolumetric contraction, what is the main goal of the isovolumetric contraction? It's to open the aortic valve, right? It's to increase the pressure in the ventricle so that it overcomes the pressure in the aorta, so the aortic valve opens. So at point N, we could say that the aortic valve opens. Just gonna ignore that. The aortic valve opens, and that's true with A. N is when the aortic valve opens. And now notice how there's still an increase in pressure, but the volume is starting to decrease, right? And this is when we have ejection of blood from the ventricle into the aorta. So you have an increase of volume, all the way until we get, or sorry, pressure, my bad. Increase in pressure, but a decrease in volume until we get to point O. Point O is when the aortic valve closes, and we have the diastole phase going, where the ventricle is now relaxed and the pressure starts to decrease. So here we have decrease in pressure and everything is relaxing. There's the end systolic volume is here. So I hope that makes sense, and I hope it explains why the answer is A. Okay, I'm going to move on to the next question. So this is a slide to explain that. And here. Okay, so a 30-year-old man has an ejection fraction of 0.25 and an end systolic volume of 150 milliliters. What is his end diastolic volume? This requires some calculations, and it also requires you to memorize some formulas. So I will give you time to come up with a calculation, and then we'll go over it together. Okay, I see D, I see C, another D. Another D. All right, great guys. Most of you are correct. It is G, 200 milliliters. And I got you. I'll explain the way to calculate it. So essentially, to calculate this, you need to know two different types of equations. The first equation is for the ejection fraction. So ejection fraction is equal to the systolic volume over the end diastolic volume, okay? But we know in this question, it gives you the ejection fraction and it gives you the end systolic. But the two values that are unknown is the end diastolic volume and the systolic volume. So we have to figure out another equation. So the other equation would be systolic volume equals end diastolic volume minus the end systolic volume, okay? Here we know the given values here, or the known values here, would be end systolic volume and ejection fraction. Okay, so ejection fraction is equal to 0.25 and systolic volume is equal to 150. Now, what I'm going to do to make this easier is I'm going to substitute systolic volume with this equation right here. So what we get is ejection fraction is equal to EDV, or end diastolic volume, minus end systolic volume over EDV. Now we can further simplify this equation. We multiply EDV on both sides. We get EDV times ejection fraction, which is equal to EDV minus systolic volume. We can further, do some more simplifications, but essentially what we get is EDV minus 1 minus the ejection fraction is equal to the sorry, that's ESV, and systolic volume. And if we just substitute the values, EDV is 1 minus 0.25 is equal to 150, and basically EDV times 0.75 is equal to 150. Then we divide by 0.75 on both sides, and we find out that EDV is equal to 200 milliliters. Okay, to make the equation a little easier, here's another slide where basically explains every single step of how to simplify the equation and how to solve. But essentially, you just need to know these two formulas, the ones in red. Whoa, you did not see that. Anyway, you just need to know these two formulas in red, and you just have to substitute the formula in the systolic volume formula, stroke volume formula into the ejection fraction formula so that it makes sense, and hopefully you can solve it. Okay, this one, the figure shown is a left ventricular pressure volume loop for a person at rest. What effect would aerobic exercise have on the maximal left ventricular afterload and slope of the end systolic pressure volume relationship? Yes, PBR line. So what do you guys think the answer is? Yeah, it's A. I feel like I ruined it for you guys. Yes, it's A, but why is it A though? Someone just told me because it's in a red box. Um, yes, but let's explain the physiological part about this, like the actual thing that we need to know. So it is A because this person is doing aerobic exercise, right? So let's first talk about the afterload. So when you're doing exercise, you're increasing the cardiac output. And also another thing is you're trying to increase the blood flow to your muscles, like for example, your calf muscles or your biceps and things like that, these muscles that are used for exercise. But what you're also doing is you're decreasing the blood supply to areas that don't require oxygen at that point. For example, your stomach would probably not require oxygen while you're exercising, or like your liver or things like that. So you are causing a decrease or like contracting the vessels to organs that are not required in exercise. And by doing that, you're increasing the systemic vascular resistance by vasoconstriction. And because of this increased systemic vascular resistance, we have an increase in peripheral resistance, which leads to an increase in aortic pressure. And when there's an increase in aortic pressure or increase in peripheral resistance, we have an increase in the afterload. Now, the ESPVR line is basically a measure of contractility or cardiac contractility. And the line or the slope of the line increases when there's more contractility. So when someone is doing exercise, there's more blood being pumped throughout the heart, there's more cardiac output happening, and therefore there's more contractility. So the slope of the ESPVR line should also be increased. So I hope that makes sense. Oh, thank you. Okay, moving on to the next part. Okay, which of the following agents or changes has a negative ionotropic effect on the heart? Okay, so I got D, I also got E. So the correct answer is D. First, I'll explain why it's D. So acetylcholine, so first of all, what is a negative ionotropic effect or ionotropic effect? Basically, ionotropic means contractility, and if it's negative, it means there's a decrease in contractility. So the reason why this is the answer is ACH or acetylcholine is because it's released by the peripheral nervous system. And the peripheral nervous system, if you remember, it's rest and digest. So your heart rate would decrease, you'd be like, your heart rate wouldn't pump as much. So ACH is a negative ionotropic. And the way it does it is it basically decreases the pacemaker potential by making it harder to reach the threshold to generate action potential. And this is because it increases the potassium efflux, which causes hyperpolarization of the membrane. So if the membrane is hyperpolarized, which means it's more negative, it's harder to get closer to the threshold, which is a positive value, and it's harder to generate an action potential. And if there's no action potential, there's no contraction. So ACH inhibits or prevents a contraction of the heart. The other answer choices, like an increased heart rate, naturally, if you have an increased heart rate, you'd have more contraction. If there is sympathetic stimulation, this is the opposite of acetylcholine release, because sympathetic is fight or flight, you're increasing your heart rate, increasing contractility. Norepinephrine is a molecule released by the sympathetic stimulation, and again, it also increases contractility. The last one, cardiac glycosides, is a compound used to treat for heart conditions and things like that, and this also increases contractility. So all the other answer choices increase contractility except for ACH, which is released by the peripheral nervous system. Does anybody have any questions? All right, so this is the end of my part for the cardiac part, and I will come again for the pulmonary part, and I'm going to give the stage to Tasneem for her part of the cardiac.
Thank you, Sidrah. That was really nice. Are you guys able to see my screen?
Yeah,
Yeah,
we
we
can.
Okay, so basically what's gonna, first of all, hi everyone. Assalamu alaikum, my name is Tasneem AlIbrahim and I'm a fourth year medical student. So just to give you an outline, what we're gonna do now is finish up with the cardiac lectures and then we'll go into pulmonary lectures. So do you guys want to break now or when we finish between cardiac and pulmonary lectures? Okay, so we'll continue with the cardiac lectures then, and then we will do pulmonary lectures. Tamam? Okay, so let's start with the first question. This is a very long question, but what it wants from you is actually very simple. Just let's read it. So, a 48-year-old man with diet-controlled type 2 diabetes mellitus is being evaluated for occasional retrosternal chest pain. He has no history of hypertension, and his blood pressure measurements during office visits were always within normal limits. There is no family history of cardiovascular disease. The patient undergoes exercise treadmill stress testing. He walks for 7 minutes on the treadmill and then stops due to fatigue, but does not experience chest pain. His EKG does not show any abnormal changes. Now, his heart rate ranges from 70 at rest to 132 at peak. Now, the question is, which stress compared to resting state in this very long vignette is that there's a patient who is exercising. Which of the following from these A to E would decrease when you are exercising? B, okay. That's an interesting thought. Any other question? Any other answers? Sorry. C, also interesting. I'll tell you why it's not C. Anyone else? Like, are you guys ready to hear the answer? Okay. So, the answer is actually E. And let's see why the answer is E. Now, let's go through each of these and tell me whether it increases or decreases when you're exercising. The first one is cardiac output. Cardiac output would increase, not decrease. The reason why is because when you're exercising, you need more blood in your muscles, right? And so your blood has to pump, your heart, sorry, has to pump more blood, so it has to pump harder, increasing your cardiac output. So A is out. Now, as for B, B is not the correct answer, and I'll tell you why. You guys remember where the veins in your body are usually located in your lower limbs? If you have a foot here, this is your foot, tamam. And okay, this is your muscle here. So you have muscle fibers like this. In between your muscle fibers, let's change the color, is your vein, right? It runs here. And so when you exercise, what does the muscle do? When you move this muscle, it pushes on the vein, right? So there's a pushing force towards the vein so that the blood can be driven upward. Why does it do that? So that it increases venous return. When you increase venous return, you're also increasing end diastolic volume and therefore end diastolic pressure, right? So you see why the answer isn't B. The next one, you said C. Now think about it like this. When you're increasing cardiac output, the right side of the heart and the left side of the heart are both pumping more blood than usual. And so you do have an increase actually in pulmonary artery systolic blood pressure, right? In the same time, what would happen is that the resistance, okay, maybe that's what you meant. The resistance of the pulmonary arteries would decrease a little bit. And that's because the blood vessels want to they want the blood to be exposed to more air, right? Because you need more oxygen. Your demand for oxygen while you're exercising is higher. So while the pulmonary artery systolic blood pressure would increase, the resistance of the arteries during this time would be decreased. For D, it is of course incorrect because we're increasing cardiac output, so the blood pressure would also increase. So this is also out. Finally, why do you think it's total systemic vascular resistance increasing? So let's look at this slide here. Okay, when you're exercising, what happens is that the vessels in your muscle and in your heart vasodilate because of metabolites. And also, you have vasodilation in your skin because you're sweating. So, you want to basically increase the blood flow in your skin. Now, overall, okay, your vascular resistance would decrease, but it would, the resistance of some vessels would decrease. For example, your kidneys don't require, they're not really required during exercise, so here you decrease. Your abdominal organs, you also don't need them when you're exercising, so the resistance there will increase and flow will decrease over there. But overall, the effect on the entire vascular system is that the resistance will decrease when you're exercising, okay? So here what they're saying is that in total, the total effect on the systemic vascular resistance is that it will decrease. Does that make sense to you guys? Does it make sense? Do we move on? Or do you have any questions? Yes. Some vessels will constrict, for example, your kidneys and your abdominal organs, and some will dilate, such as those in your heart and in your skeletal muscle and in your skin. But overall, you have a decrease, as you can see here, in resistance. Tamam? The diastolic pressure, do you mean the end diastolic pressure? The end diastolic pressure is going to increase, right? Because we're increasing venous return. And if you mean diastolic blood pressure, that will also slightly increase, yes. As you can see here, the mean arterial blood pressure also increased. Pulmonary diastolic blood pressure, yes, it will increase a little bit since we have more blood in there. But the overall effect in the pulmonary system would be that they are more vasodilated. Anytime. Okay. So, shall we move on, guys? This is just a graph to illustrate what happens. Let's move on to the next question, okay? So, this is also a long question, and this is actually a math question. So, a 63-year-old man with long-standing hypertension has undergone multiple changes in his antihypertensive regimen over the years with only minimal improvement in his blood pressure. A CT study of his thoracolumbar spine is performed for evaluation of chronic back pain, and the study incidentally finds a small right kidney. Angiography demonstrates atherosclerotic narrowing of the right renal artery. The left renal artery is intact. You conclude that the flow in the right-sided artery is decreased by a factor of 16 compared to the left. What percentage has the radius of the lumen been reduced? So here they gave you the flow. They told you the flow is decreased by 16, and they want you to find the radius. So I'll give you guys some time to answer this. But in the meantime, you can tell me what kind of equation you use to find the answer. There are two equations that you want to use in this question. Okay. Let me show you the equations that you'll be using. The first one is the equation for flow, which is flow equals to change in pressure over resistance. The second one you want to use is one that has the radius, and we will use the resistance equation. I'll give you a little bit more time to solve this. C, nice, okay. Any other answers? time. Let's see why this is C. Correct, Hannah, mashallah. This is indeed C. The reason why is because what you're looking for is to find the radius, right? And you were told what flow is, which is that basically it was decreased by 16. So to get to the radius, we're going to combine these two by substituting the radius, the resistance equation here, here. So first of all, let's start with this first equation. Resistance equals to 8 NL over pi r to the power 4. Can you guys tell me what N is? Viscosity. Great. So N is viscosity and L is length. So what we're going to assume for this equation is that all of these, this part of the equation, is all constant, okay? And so I'm going to ignore the whole thing and focus on the relationship between the resistance and the radius. And so we're going to say that the radius equals to 1 over, resistance equals to 1 over the radius to the power of 4, okay? We're going to assume that all of these equal to 1 and that they are all constant and that the patient does not have any problem except for an issue with the radius, okay, which is that the radius of his renal artery was reduced because of an atherosclerotic plaque. Knowing this, I'm going to substitute and say flow equals to change in pressure over, since it's 1 over r, I'm going to flip this equation. Okay, since r equals to 1 over r radius to the power of 4, I can also say that 1 over r equals r to the power of 4. So I'm just going to write here times r to the power of 4. Okay, and I'm going to also assume that the change in pressure is constant. There is no change in pressure. So I can now say that flow equals to r to the power of 4. Do you understand how this happened? We basically assume that everything in this patient is normal except for the change in flow and radius. And so by just substituting these values, I was able to reach that flow is equal to the radius to the power of 4. And now, when we look at this, they told us the flow is decreased by a factor of 16. So I'm going to divide this by 16. And what you do on one side of the equation, you do on the other. So we're going to also put over 16 here. And now, what do you know about 16? If we are going to simplify this part of the equation, then I can say that it equals to r over 2 all under 4, because 2 times 2 is 4, times 2 is 8, times 2 is 16. And so as you said, the answer is by 50%, because this is basically telling me that 1 over 2 times r is the answer, okay? And so this is why the radius has been reduced by 50%. These are the equations that you were given in the lecture. And here we're saying that the only thing that they really ask you about is the radius. The length rarely changes, and the viscosity of the blood also rarely changes, at least in your scenarios. But the viscosity of the blood can change clinically, for example, if you have anemia. But for your questions and for your level, they're really only going to ask you about the radius. And so when you come here, what I'm showing you in this question is that they can ask this question in reverse. So instead of asking you, or instead of starting with the flow, they can have you start with the radius. So here they're telling you that a 53-year-old woman is found to have 50% narrowing of her left renal artery, which is basically telling you that you're starting out with 1 over 2 times r. And what is the expected change in blood flow? So again, they're asking you about flow. So you can do the same thing here. We know that now flow equals to r to the power of 4. And we know that here what we have is r over 2. And so if we do the math, we end up once again with 1 over 16, since 2 to the power of 4 is 16. So the answer here would be D. Does this make sense to you guys? Great, alhamdulillah. If you have any questions, just stop me at any time or text me on the chat. Tamam? So let's move on. Here's another question. The greatest pressure decrease in the circulation occurs across arterioles because this is just a recall question. Excellent. Okay, I'm seeing A and E. طيب. So the correct answer is E, but I want to know why do you think it is A? So if you look at how the cardiovascular system goes, we have the heart. Okay, this is a very badly drawn heart. And then you have the aorta. From the aorta, we have arteries, and then we have arterioles. And finally, we get to capillaries. Okay, many capillaries. And so this means that the greatest surface area actually goes to the capillaries, right? Since there are many of them and they're all dividing in parallel. You should know this detail. Tamam? So the first A is incorrect because the greatest surface area is actually for the capillaries. And the greatest cross-sectional area also goes for the capillaries. Now, why do they have the greatest resistance? Arterioles are vessels of resistance, and the reason why is because once you go from arterioles to capillaries, you're going from very histologically different vessels. The capillaries are really thin and delicate, while the arterioles actually have smooth muscle around them. Tamam? So we go from really high pressure going into the aorta and the arteries and then into the arterioles, and we need to regulate this blood pressure so that we change the blood flow to organs however we would like to change it. And we do that with the arterioles. Tamam? The arterioles are the ones that regulate this blood pressure, and that's why they have to have the greatest resistance. Okay? And you can see here that the blood pressure drops here and greatly drops in the capillaries. So before it goes into the capillaries, we need to regulate it. Sometimes when you're exercising, you need to increase it. Sometimes when you're eating, you want to increase it, you want to decrease it in other parts. And so this is why the arterioles are the ones that have the greatest resistance. Both because they are the ones that are controlled, but with their smooth muscles around them, and secondly, because they need to protect those capillaries. We can say capillaries are the ones, but actually capillaries are divided in parallel, not in series. Do you see what this division here is? We go from aorta to artery to arteriole. These are all in series. So the blood pressure here is all the same. Once you go into capillaries, the capillaries are all divided. So the pressure now is in parallel. And that's why you have a great decrease in the pressure. Does this make sense to you guys? Shall we move on? So, a 75-year-old man with no serious health complaints is scheduled for a routine cardiovascular checkup. What is expected for his arterial compliance as compared to a healthy 25-year-old man? And what effect will this have on his arterial blood pressure and cardiac work? They're basically asking you, how does aging affect the arteries? Okay, I'm seeing B. Great, that is correct. So when you age, what happens is that the elastin in your body decreases, the production decreases, and you don't have as much of it anymore. And so the elastin is present in your arteries, right? And mostly in your aorta. You find that old people, for example, they have sagging skin and so on. In the same time, what's happening to their arteries is that they're becoming stiffer since they cannot expand as much anymore. And so that means that they're not as compliant. When you have a stiff vessel, you can't fill it up with as much fluid, right? It won't expand as much as one that has a lot of elastin and is willing to accommodate the amount of fluid you're putting in it. And so that means that compliance is going to decrease. So I can eliminate E and I can eliminate C. Now, how would that change the arterial blood pressure? When you have a vessel that is more resistant, it's more tough, the pressure in the artery will naturally increase. And so that means that I'm looking at, I can remove A as a potential answer, and now I'm left with B and D. Now, do you think that your heart has to work harder when there's more blood pressure, or does it have to work less? Of course, it will have to work harder when the blood pressure or the pressure against its pushing is higher. And so that means that you will have to do more cardiac work. And so the correct answer is indeed B. Okay, so here we can see that there's a change in compliance. That means that your elastance is decreasing. And when you have more stiffness, you have more pressure, and you have to do more, your heart has to do more work. Decreasing compliance increases blood pressure. Yes, you can also think about it as stiffness. Do you see this relationship? Stiffness equals to change in pressure over change in volume. When you increase the change in pressure, these are proportional to each other. So a proportional increase in stiffness will proportionally also increase the pressure. And so if you have more stiffness, and that also means less compliance, you will have more higher blood pressure. Okay? Like, so are we good with that question? Excellent. Okay, let's move on. So, a 46-year-old man presents with edema of the right leg following a surgical procedure to repair a torn calf muscle on the right side. The edema is unilateral. His serum proteins and electrolytes are normal. Which of the following pressures will be most directly affected by this edema? Focus on the fact that this is unilateral and that serum proteins and electrolytes are normal. He also had a surgery. Okay. So what do you think the answer is? A. Okay. A isn't wrong, but I want you guys to tell me the one that will be most directly affected. Remember that this patient had a surgical procedure and that the edema is unilateral. The edema being unilateral versus bilateral should always give you a very strong differential diagnosis. Whenever someone tells you that they have edema, you should be concerned about which side the edema is on. C. Indeed, C is the correct answer. So why is C the correct answer? Let's look at this slide here. This slide tells you the examples of edema and what changes will happen in the body. Now, this patient has the pressure that is affected here is the interstitial hydrostatic pressure. That is because this patient had a lymphatic injury. And when your lymphs cannot take up all of this blood, it will be left over in your leg, and that will cause edema. And so that's why the interstitium, which the lymph is responsible for, is the one that is affected here. Now, some of you said A is the correct answer, and A is not wrong because it is secondarily increased because of the lymphatics being unable to take the fluid. The capillaries will have some extra fluid in them and increased hydrostatic pressure, but it will not be substantial, and it is secondary to the interstitial hydrostatic pressure, the one that is contributing the most to this edema in the leg. And as you can see here, increase in interstitial pressure is mostly due to lymphatic obstruction. Sometimes they can tell you that a woman has a unilateral arm edema and that she is post-mastectomy. So sometimes when they're removing one of the breasts, they will injure the lymphatics in the arm, and that will cause edema in only one single arm, which is the one that was affected. In this patient, they told you that they had a surgery in his leg, right? So it matters to you that this is unilateral because it can point you more towards something lymphatic. If I tell you that this is a bilateral edema, and for example, the patient has dyspnea, then maybe you're thinking of congestive heart failure, right? And you're thinking of high capillary hydrostatic pressure. If I tell you that this is a patient who has liver cirrhosis and he has edema in both of his legs, and maybe he also has a distended abdomen, you will most likely think of plasma oncotic pressure being affected here, and you will think of liver issues, right? But here in this patient, they told you serum proteins and electrolytes are normal, so that should have excluded that from your differential diagnosis. Does that make sense to you guys? Why it's not A? The significance of unilateral/bilateral. Surgery always interests, not exactly, it's not always, but it should give you a hint, right? So, and unilateral versus bilateral, we just explained it. So if you have an issue with your liver, if you have an issue that is systemic, basically, not something that is local. If I have an issue that is local, I'll most likely have a unilateral edema. If I have an issue that is systemic, affecting the entire body, like for example, liver cirrhosis, starvation, congestive heart failure, I'm affecting the entire body and the entire circulation. Heart failure. Okay. So what happens in heart failure? Your heart is not pumping. There's a pump failure, right? Your heart is not pumping as it's supposed to pump. And so you have edema in your body since the fluid starts backing up, right? And when that happens, the fluid will leak into the rest of your body and you will have edema. Does that make sense to you, Hannah? Great. So surgery does not always equal interstitial. It just should give you a hint that the lymphatics probably were obstructed. So if you combine a history of surgery with a unilateral edema, that should point you more towards having something that is interstitial and that is lymphatic in origin. Does that make sense? And you're not always thinking about lymphatics, because something else that can cause unilateral edema is DVT, which is basically having a thrombus in your veins in a single leg will cause unilateral edema in that single leg and not the other leg. And so you should also think about, maybe they will tell you that the patient has some kind of issue, for example, with his clotting factors, or maybe the patient is a pregnant woman who was on a plane for a long time. So you should take the entire scenario into consideration before you decide on what the issue is. Doesn't increase interstitial hydrostatic pressure, decrease filtration. Yes, but what do you mean? Filtration is decreased when you increase the interstitial hydrostatic pressure. That's why you have edema. Okay, Anna? But let's move on to the next question. What decreased? Do you mean the filtration? When you increase, so the interstitial hydrostatic pressure in this case is increased. That does decrease filtration, yes, if the forces are opposing. But still, you will have an increase in, okay, tamam. Anytime. Okay, let's move on to the next question. So, a 60-year-old woman has a resting heart rate of 70 beats per minute, arterial blood pressure of 135/85, and a normal body temperature. Use the pressure volume diagram of her left ventricle below to calculate her cardiac output. So again, this is a mathematics question, and you need to use the values in this diagram to calculate the cardiac output. So I'll give you guys a minute to calculate it. E, correct. So what is the equation for cardiac output? First of all, here, the cardiac output equation is equal to stroke volume times heart rate. We already have the heart rate, which is 70, and now we need the stroke volume. The stroke volume can be calculated from this diagram here. So in this diagram, they already labeled it for you. we know that this one is end diastolic volume and this is end systolic volume. And stroke volume equals to end diastolic volume minus end systolic volume, which means that it's 150 minus 50, which equals to 100. So now we have the stroke volume, and we can substitute it here. And 100 times 70 equals to 7,000, or E. Perfect. But more math. So here, they're telling you that they're giving you the capillary pressures, and they're asking you to use the Starling equation to calculate the net driving force. I'll give you guys some time to solve this as well. Were you guys able to solve it? Excellent. You guys are so smart. MashaAllah. So what you do here is, first of all, what is the equation? You need to subtract the hydrostatic pressure, both here, and you need to subtract the oncotic pressures, and then subtract the two from each other. And so 30 minus 2 is equal to 30 plus 2. 30 plus 2, which is 32. So this is the hydrostatic pressure. And then the oncotic pressure is 25 minus 2 equals to 23. And if I subtract the 2 from each other, I will get 9. And so that means that both of these are out. Of course, there is a net fluid movement, and so I have 9. Oh, wait, where is 6? Okay, so is it absorption or is it filtration? Here, you need to look at, first of all, which one is higher. Is it the capillary hydrostatic pressure or the oncotic pressure? And in this one, hydrostatic pressure is higher, and so I definitely have filtration going on. And so the answer is indeed D. And this is the slide that explains this for you. You can also look at it by seeing whether the answer is positive or negative. If the answer is negative, then that means it's absorption. But you can also just look at which value is higher than the other. So let's move on. So a 55-year-old man presents with complaints of dizziness and shortness of breath on exertion. The physician detects a murmur heard during the portion of the cardiac cycle labeled X on the image. Which of the following heart valve pathologies would most likely produce this murmur? So when you're talking about murmurs, you want to know whether this murmur is a systolic or a diastolic murmur. Okay, I got one answer, which is A. First of all, is this a diastolic murmur or is it a systolic murmur? Diastolic. Excellent. And so now here you want to eliminate everything that does not produce a diastolic murmur or produces a systolic murmur. So let's start eliminating. First of all, A, aortic valve stenosis. Now, when you have aortic valve stenosis, what you have is basically an aortic valve that is hard and stenosed, and it has a narrower opening. It does not open as well as a normal aortic valve. And so when you're pushing blood through the stenosed aortic valve, you will cause a sound or a murmur. And when does this sound get produced? it gets produced during systole, not diastole, because that's when the blood is going through the aortic valve. And so A is a systolic murmur, therefore it is out. Good. B, mitral valve stenosis. So that before we go on to B, look at C. C is a pulmonic valve stenosis. I'll treat it the same as I treat the aortic valve stenosis, since blood goes through both of them during systole. And so these two are out. Now, back to B, mitral valve stenosis. Is this a diastolic murmur or systolic murmur? Diastolic. Great. Why is it diastolic? Because you have the mitral valve, which is between the atria and the ventricle, right? And so remember that when you have um, when when you have diastole, and the blood is filling, it's going into the atrium, and then from the atrium it goes into the ventricle. The last stage is for the atrium to contract to push the remaining blood in the atria into the ventricles. Now, when this atria contracts, it pushes blood through the stenosed mitral valve. And as we said, the opening is really narrow this time. It's not like the normal non-pathologic mitral valve, and so it will produce a sound or a murmur, and it will be in diastole, since that's when the blood is being pushed through the mitral valve. And so that's why this is a diastolic murmur, so we will keep it. Next, we have mitral valve and tricuspid valve regurgitation. These two produce, yes, these are all physiology questions. These will produce systolic murmurs, not diastolic, because these valves, when you are pushing blood in systole, since you have regurgitation or backflow of blood, the blood will flow upwards into the aorta and into the pulmonary valves, and then it will also flow into whatever valve has regurgitation, producing a sound. And so these two are both out, since they are systolic murmurs, leaving you with B, mitral valve stenosis, as the correct answer. Does this make sense to you guys? So what you guys need to know is each of these and what kind of murmur they produce, and then explain to yourself why you think that's the answer. And you need to be familiar with this graph, because instead of telling you this is a systolic or diastolic murmur, they can just give you this graph and tell you, okay, the murmur is here or the murmur is here. Tell me which one it is. So here is a table that I put for you guys so that you can review all of the murmurs. And what I want you to focus on is S3 and S4. S3 is always associated with volume overload. When you have a lot of volume and this volume is hitting the ventricle, you get the murmur of S3. And so this is usually an early diastole, so you will find it here. Meanwhile, S4 is usually because of pressure overload. Okay, the pressure in the ventricles is really high, and that is what causes this murmur. So when you have volume overload, you will have volume overload either in pregnancy, this is the most important thing, aortic or mitral valve regurg, and heart failure. Why heart failure? Because as we said, the heart as a pump is not working so well, and so the blood in the heart will not be very, like, it will not leave as well. The cardiac output will decrease. There will be an increase of blood in the heart, causing the heart to become dilated like this, having eccentric hypertrophy, because there's so much blood in it that it's making it more dilated. And so this will be producing an S3 murmur. Meanwhile, in pressure overload, you have increased pressure. So for example, let's just say that the person has a stenosed aorta, or they have hypertension. What's happening now is that their heart has to pump harder because there's an increase in pressure. There's something that is against its force, right? When you have uncontrolled hypertension, the blood pressure in the blood is so high that the heart has to pump harder. And when you have a stenosed aorta, you also have an increased pressure against the heart. And so now the heart has to work harder. And whenever a muscle has to work harder, what does it do? It grows, right? And so this time, the hypertrophy is concentric, because the heart has to recruit more fibers so that it can counter all of the pressure that it is trying to overcome. Does this make sense to you guys? Do you want me to repeat any point? Again, if you have any question, just stop me at any time. So the next question says, in the figure shown, the left ventricular pressure volume loop of a patient is shown when healthy, which is the solid red line, and after chronic manifestation of a disease, which is this dashed line. Which of the following diseases most likely caused the shift from solid to dashed in this patient? E, correct, mashallah. تمام. Why is it E? First of all, let's look at this graph. The x-axis is for ventricular volume, and the right axis is for ventricular pressure. Notice here that the pressure in the ventricle is very high, right? And so this ventricle is working very hard. And so the answer here, it cannot be aortic regurgitation, because aortic regurgitation does not give you a high pressure to work against. It cannot be left heart failure, because look at the volume of the ventricle, it has not changed, and we said that we have an increase in volume in heart failure, so that is out. Mitral valve stenosis would not give you this kind of view, because the left ventricle is not working against any hard pressure. The issue here is that the ventricle actually um, should not have this much blood pressure working against, right? When you look at this high blood pressure, you need to think about something that the heart is working hard against, so that the pressure in it is so increased. And so it's not C. And pulmonary hypertension, here we're talking about the left ventricle, right? Not the right ventricle. If we were saying this is the right ventricle, then you would pick D. But since we're talking about the left ventricle, indeed you will pick E. تمام. Do you guys know what else might cause this kind of what valvular pathology might give you this kind of graph? Excellent, aortic stenosis. So again, in this kind of pathology, the heart is working against high blood pressure or high pressure, and so it has to work harder to pump blood through this very thin opening. Okay, and which heart sound do you expect to hear? Since the pressure here is so high, so you need to think about something that causes pressure overload. S4, amazing. MashaAllah, tamam. So this is the slide that talks about it. And here again, you have decreased stroke volume, as you can see, increased end systolic volume, and S4 heart sound. That's the most important thing you need to know. Like, so here's another question. An otherwise healthy 27-year-old woman is referred to a cardiologist because of a murmur detected by her general practitioner during routine health maintenance examination. She has history of recurrent episodes of sore throat and fever during childhood, and she immigrated from Kenya 6 years ago. This is all just to confuse you. So cardiac examination shows an opening snap followed by a late diastolic rumble, which is heard best at the fifth intercostal space in the left midclavicular line. Which of the following pressure volume loop graphs is most likely to correspond to this patient's cardiac condition? So they give you a lot of words, but what you need to know here is it's a diastolic murmur and where they heard it. D. Okay, excellent. So what is D? What kind of graph is this? Mitral stenosis. Excellent. You guys are really, really smart, mashallah. Indeed, this is mitral stenosis. So you can see here, unlike aortic stenosis A, there is no increase in pressure. What we do have is that there's an increase in the end systolic volume, right? The end diastolic volume is decreased. So let's look at it here. As you can see here, there's decreased preload, decreased afterload, and decreased stroke volume. And here you have a dilated hypertrophy. They have a systolic murmur with atrial dilated hypertrophy. So what's happening here is that blood is coming into the atria, right? But the mitral valve is stenosed. So it cannot go into the ventricle as well as it can. And so the atria is dilated. Okay, and as a result of blood not entering the ventricle as well as it should, the preload is decreased and the afterload is also decreased since the cardiac output is not as high as it can be. And so you can see here that it's reflected in this graph with decreased end diastolic volume and slightly decreased also end systolic volume. Does this make sense to you guys? And we know that mitral stenosis is a diastolic kind of murmur, right? And if you look here, you need to know this very well, where you can listen to each heart sound. And they told you that they listened to in the left midclavicular line, right here, which is for the mitral valve. Okay, does this make sense? Shall we move on, or do you guys want to ask any question? So the next question is, a 30-year-old woman experiencing tachycardia begins to massage the carotid region of her neck, which quickly reduces her heart rate. Which of the following mechanisms is responsible for this phenomenon? D. Excellent. So what's happening here is that when you massage your carotid region, you are stimulating the baroreceptors. And when you stimulate them, they will increase firing to the nucleus tractus solitarius. Okay, and once you increase firing to the nucleus tractus solitarius, what it will do is that it will slow down your heart rate and it will have an increased parasympathetic stimulation. Tamam? So what is another way for these baroreceptors to be stimulated? Other than manually massaging them. Excellent. If you have high blood pressure, they will be stretched, and that will also cause them to increase firing. Tamam. Okay, next question. A 23-year-old man comes to the emergency department with sudden onset of heart palpitations that started while he was at his desk at work. The patient has no known medical problems and does not use tobacco or illicit drugs. He drinks alcohol occasionally on the weekends. Initial blood pressure is 110/70 and pulse is 160 and regular. Gentle neck massage just below the angle of the right mandible provides immediate improvement of his condition. His blood pressure is now 120/80 and pulse is 75. Which of the following mechanisms is responsible for improvement of this patient's condition? So this is a very similar scenario. Increased sympathetic output to the sinoatrial node. Okay, look at his blood pressure changes. In the beginning, his blood pressure was 160. Now it's 75. If you increase sympathetic stimulation to the sinoatrial node, you will have an increased firing, which will increase the heart rate, but the heart rate decreased, so it cannot be B. D. Prolonged atrioventricular refractory node, and I'm also seeing C. Increased systemic vascular resistance. And I'm also seeing E. Prolonged ventricular myocardial. Okay. Like, the correct answer is none of you. The correct answer is D. Tamam. Why is it D? Now, what happened is that the baroreceptors fired, and they then sent a message all the way to the nucleus tractus solitarius. When the nucleus tractus solitarius got this message, it understood, okay, now I need to decrease the blood pressure, and I need to decrease the heart rate. And so what this did is that, first of all, you massaged the baroreceptor, so you increased the firing rate, so it's not A. You cannot, if the nucleus tractus solitarius fires, it will decrease the heart rate, which means that the sympathetic output to the sinoatrial node should decrease, so it's not B. Increase systemic vascular resistance. When the nucleus tractus solitarius fires, okay, why is it firing? Because the baroreceptors are telling it that the blood pressure is really high. We need to lower it. And so the systemic vascular resistance would actually not increase, it will decrease. Then you said E. Now, you have to understand this. The heart is controlled by the electrical system, right? And so the ventricular myocardium is not the one that is controlled. What is controlled here is the atrioventricular node and the sinus node, tamam? Not the ventricular myocardium. And so the refractory period would actually be prolonged in the AV node. That's the one that has the refractory period, right? Because don't you, remember that you have the atria right beside each other, and then you have the ventricles. And you have the sinus node here on one end and the AV node. When the sinus node fires, the atria will contract, and then it will send a signal all the way to the AV node. The AV node has to wait a little bit before it fires and tells the ventricles to contract, and because you need time for the ventricles to fill up with the blood that the atria are contracting into it. And so there is a refractory period in the AV node, not in the ventricular myocardium. This is the part that you want to lower or prolong, okay? So do you guys understand why it's D? Amazing, okay. Let's move on. So if you have any questions, stop me at any time. When blood pressure is measured with a sphingomanometer, blood flow through the brachial artery is temporarily increased above normal immediately following deflation of the blood pressure cuff around the arm. Which of the following correctly describes this change in blood flow, and what are the primary local metabolites responsible for the change in flow? E. Okay. Correct. Amazing. Why is it E? First of all, we know that we have two types of hyperemia: active hyperemia and reactive hyperemia. Active hyperemia, when does it happen? When you have, for example, increased activity in a muscle or a part of your body that needs blood, so you have active hyperemia. It's an active part that your blood pressure, your blood vessels are doing. Meanwhile, when you have reactive hyperemia, you have increased flow reacting to something else, for example, an obstruction. So here what they told you is that this, you guys know how blood pressure is taken, right? So what they do is that they put this cuff around your upper arm and they inflate it so much that they compress the brachial artery. When they compress the brachial artery, blood flow stops. And then once they've taken blood pressure, they deflate this cuff, so blood flow is returned. And this is known as reactive hyperemia, because there's an occlusion that was removed. And so this is reactive. Now, what are the metabolites involved? This is a purely recall question. They are adenosine and potassium. Does this make sense to you guys? If it makes sense, let's move on. The next question says that cardiac output and venous return curves are shown in this graph. Which of the following most likely depict the cause of change depicted by the dashed line? So what made this cardiac output line move downwards? You're all saying D, and that is indeed correct. Myocardial infarction caused the cardiac output to decrease. Myocardial infarction just means that part of your heart died. When part of your heart dies, your heart cannot pump as well as much as it can anymore. And so that will decrease the cardiac output. So what you need to know for this kind of concept is what will move this venous return curve and what will move the cardiac output curve and how they will move. So For the venous curve, which is this one here, okay, the venous return one, the parameters that will increase it are increased blood volume, so more volume of blood in the veins, decreased venous compliance, which means that you have an increase in venous return, and then you have decrease in arteriolar resistance. And then the opposite will happen if you switch them, they will decrease venous return. Now, for the cardiac function curve, the things that will increase cardiac output is increased sympathetic stimulation, which we said increases the heart rate and therefore the cardiac output. Increasing circulating epinephrine. Epinephrine just is a stimulating hormone. It's basically these two are the same. They have the same effect. So they will both increase cardiac output. That's the positive inotropic drug. And finally, if you lose your ventricular tissue, then you will, of course, decrease the cardiac output because the heart as a pump is not pumping as well as it can, as well as it was before the, for example, myocardial infarction. Does this make sense to you guys? Like, the next question says that you have a 17-year-old girl with orthostatic hypotension, presenting with complaints of multiple synovial episodes over the past month when standing up. So she has orthostatic hypotension. To prevent syncope, which of the following changes to cardiac output, arterial resistance, and venous compliance occur as part of the normal baroreceptor reflex in a healthy person when standing up? So what are things or changes that should occur in order for her not to have orthostatic hypotension? You guys are saying B and C. Okay, let's go through them. The correct answer is C. Now, when you have orthostatic hypotension, it's because the blood is not returning very well to your brain, and so you are feeling dizzy. To decrease that, first of all, the cardiac output has to increase. So I can remove all of these. I'm just left with A, B, and C. Next, arterial resistance. Should it increase or decrease? It should increase, right? Because you want to increase the venous return as well to the heart, and so it should increase. And finally, venous compliance should also. Now you said B. So B basically is same. So you have to decrease venous compliance. When you decrease venous compliance, you're also increasing the return of the blood to the heart. Now, why should arterial resistance increase instead of decrease? Because you have baroreceptors, right? And you need to increase the sympathetic flow. When you have increased sympathetic stimulation, these will constrict. Exactly. So you have vasoconstriction. And so the arterial resistance should increase. And here they basically gave you all of this on the slide. So they told you have arteriolar vasoconstriction, venous constriction, and you also have increase in heart rate and contractility, which in turn increase the cardiac output. TPR will increase, or it should increase basically, since we are increasing the arteriolar resistance, which are the determinants of resistance in the body, right? Does this make sense to you guys? Let's move on. So, in an experimental procedure, blood flow to the leg muscles of a mouse is measured at rest and again during exercise. And during exercise, blood flow to the leg muscles triples compared to rest. Why is blood flow increasing during exercise? What is the cause? Yes, in exercise, TPR will decrease in total. Correct. So the answer is D. When you exercise, how does blood flow increase to your muscles? They increase because your muscles are working harder and producing metabolites, right? And we call this active hyperemia, and that causes the vasodilation. So your answers are all correct, mashallah. But the next question says, When the Valsalva maneuver is used as a cardiac function test, the patient is asked to forcibly exhale against a closed glottis. The testing physician monitors the normal physiological body response to continued strain about 10 to 25 seconds after the beginning of the test. Arise in which of the following is monitored? So you're saying most of you said D, but one of you said B. The correct answer is D. What you monitor in the Valsalva maneuver is heart rate. What happens basically is that you are straining. And when you strain, you're increasing the pressure in your thoracic cavity. And when you increase that pressure, in the beginning, your heart rate will fall since the pressure is so high, but then it will increase, okay? Because the venous return to the heart is decreased. And so the heart will think, oh no, something is wrong here, and so it will increase the heart rate. And so what you monitor in the Valsalva maneuver as a physician, the only thing you can monitor is not aortic pressure, but heart rate. تمام? We want to know, are your baroreceptors confident enough or competent enough to eventually cause your heart rate to catch up and increase when they're not? This is something that you can monitor in the clinic. Does this make sense to you guys? Let's move on. So a 28-year-old man is brought to the emergency department 10 minutes after being involved in a high-speed motor vehicle accident. His only complaint is severe abdominal pain. He appears anxious, and his pulse is 112 and blood pressure is 109/75. Physical examination shows abdominal guarding, weak pulses, and clammy skin with delayed capillary refill. Abdominal ultrasound shows a large amount of intraperitoneal blood and a large left-sided perinephric hematoma. Which of the following best explains this patient's normal blood pressure, despite evidence of active bleeding? So here you can see that this patient has internal bleeding, and despite him being bleeding, his blood pressure is normal, and his pulse is slightly increased. B. Correct. You guys are really smart, mashallah. The answer is B, decreased capillary hydrostatic pressure. What's happening here? Do you guys know what this is called? When you bleed a lot, but initially you're fine and your blood pressure is normal. What is the patient in, first of all? What kind of condition is this called? He has clammy skin, weak pulses, he's bleeding internally. This is shock. Excellent. This is hypovolemic shock since he is losing blood, but the specific kind of shock he's in is compensated shock, right? Because his vital signs are for the most part normal. And the reason why is because we have increased vascular resistance, right? And increased heart rate, of course, as we saw, increased cardiac contractility comes with the heart rate and decreased venous compliance. The reason why this is happening is because the patient is still relatively stable and his body is trying to compensate for the loss of volume. And so when you increase this resistance in the capillary, in the arterioles, you will decrease the capillary hydrostatic pressure. Okay? Does that make sense? Excellent. Let's move on. You have a patient with right-sided heart failure presenting with shortness of breath. Tests reveal right ventricular hypertrophy, a systolic murmur, and pitting leg edema. There is no indication of left ventricular failure. Which of the following hemodynamics changes is expected in the pulmonary capillaries? Now remember here that the patient has heart failure, which means the heart as a pump is failing. A. Nice. What else do you guys think? A. Okay, excellent. The answer is A. And the reason why is because we know that the right side of the heart pumps blood to the lungs, right? And if the heart as a pump is not pumping so much as well as it used to, then the capillary hydrostatic pressure the blood usually exerts is going to decrease, which means that the pulmonary capillary hydrostatic pressure will decrease. Tamam? There is no mention of any liver disease and so on, so colloid pressure will be not affected. There's no injury to the lung, so the interstitial colloid pressure will also not be affected, nor will the interstitial um, hydrostatic pressure be affected. تمام? Excellent. Okay. So, is capillary hydrostatic pressure also affected by volume of blood that flows through? Yes, for sure. If you have more blood going into a vessel, then you have more pressure being exerted on the vessel. And so the pressure will increase, and the hydrostatic pressure yani, that is being made by the blood will increase. Okay? Anytime. Like, oops, okay. Tamam. So, a 64-year-old man with a history of mitral valve stenosis presents to his general physician with complaints of difficulty breathing. If the patient is diagnosed with left heart failure due to chronic mitral valve stenosis, which of the following cardiac findings will most likely be present? Now, here we're saying that the initial thing that the patient has was mitral valve stenosis, which means that the blood is not being emptied very well into the ventricle. Since this opening is so narrow. E, pulmonary edema. Okay. Any other answers? Excellent. The answer is E, pulmonary edema, because you have to remember that what empties into the mitral, into the atrium, the left atrium, it's the lung. And if you have the lung emptying into a sac that is filled with fluid that won't empty properly because its opening is so narrow, which is the mitral valve, then this fluid will back up into the lungs. And when you have so much fluid in the lungs, when you're unable to clear this fluid, you will eventually get pulmonary edema. And so the correct answer is E. So here you guys just have to know what the effects of left-sided and right-sided heart failure are and what they caused on both the lungs and the whole body as a whole. So for example, in left-sided heart failure, you should remember that you have pulmonary edema, your left atrium will be enlarged, and it will lead to heart failure eventually, and the patient will most likely have symptoms of, for example, dyspnea. In right-sided heart failure, you could have elevated jugular venous pressure, since the jugular vein that is eventually becoming the superior vena cava is unable to put all the fluid that it has into the right failing heart. Huh? Excellent. Okay. So last question for the cardiology part. In hypovolemic shock, the hydrostatic pressure will what? Well, the oncotic pressure is constant. Will it increase, will it decrease, or will it not change? I'm seeing C and B. Tamam. The correct answer is yes, excellent. The correct answer is C. So what does hypovolemic shock mean? Hypo means low, and volemic is volume. Hypovolemic shock means that you have a decrease in volume. This usually happens because of hemorrhage, where the patient is losing blood. And so when you have a decrease in volume of the blood will not be there to, or there will not be as much blood to exert pressure against the capillaries and the vessels of your body. And so the pressure against these vessels will decrease, and therefore the hydrostatic pressure exerted by the blood will decrease. Oncotic pressure is unaffected because you don't have anything that is affecting the particles themselves that are causing oncotic pressure. So no change in the liver, for example, nothing related to oncotic pressure is happening. It's only hydrostatic pressure of the blood that you're losing, since you don't have enough blood to exert this pressure. Tamam? Does that make sense? So if you guys have any question, you can let me know at any time, and I'll put my phone number in the chat. The cardiac part of this session is done, and the next part will be the pulmonary part. So do you guys want to take like a 15-minute prayer break? Yes, go ahead. Yes, Batu. Okay, first let's, can we pause recording? Let's just, I'm not sure how to do this. Like, now we'll continue with the pulmonary part. I'll do the first few lectures, and then inshallah Sidrah will come back to finish up the session with you guys. So let's go through the first question. Here, basically, it's about true and false. So which of these statements is true? All of them are false except for one. C. Okay. B. The volume of the lung is 5 liters, and E. Like, so we have C, we have B, and we have E. Let's go through this one by one. First of all, what is the volume of the conducting zone? This is purely a recall question. It is not 50 milliliters, it is 150 milliliters. So A is out. Next, B. The volume of the rest of the lung during resting conditions is about 5 liters. So during resting conditions, the volume of the lung is not 5 liters, but it is 3 liters. The 5-liter volume is when you are filling it up like max. Okay, so the max you can fill up your lung is around 5 to 6 liters. So B is out. Next, you said C. A respiratory bronchiole can be distinguished from a terminal bronchiole because the latter has alveoli in its walls. What this is telling you is that the respiratory or the terminal bronchiole is the one that has alveoli in its walls. But which of these do you think has the alveoli? It is not the terminal bronchiole, it is the respiratory bronchiole. I think I have a picture somewhere here. Okay, here, you see? So these are the terminal bronchioles. They don't have alveoli. The alveoli start here at the respiratory bronchioles. So that would mean that C is also wrong. And then you have D. On average, there are about 3 branchings of the conducting airways because before the first alveoli appear. That is also incorrect because you can see here that we actually have a total of 16. And so this is also out. And then E, in the alveolar ducts, the predominant mode of gas flow is diffusion rather than convection. And this is correct. Why? Because in alveoli, how does oxygen go from here to here? It has to diffuse. Convection happens in the beginning here. And then slowly, as you move from the trachea all the way to the respiratory bronchioles, we switch from convection to diffusion. Is conducting zone the dead space? Yes. This is called which dead space? What do you call this dead space. There's a specific term that you need to use. Excellent, yes. So this is called anatomical dead space. Why is it dead space? They're just calling it dead space because there's no gas exchange happening here. Since we don't have alveoli, no gas is being exchanged in this part. And so this is called anatomical dead space. Tamam? It's just a way, and it's the corridor that the oxygen has to go through before it goes to the final place, which is the alveolus, so that it can go into the body. Tamam? I hope this makes sense. Let's go to the next question. The only variable in the following list that cannot be measured with a simple spirometer and stopwatch is... So you're in the clinic and you have a spirometer and you have a stopwatch. You have nothing else. So which of these can you not measure? B, B. Excellent. The answer is B. So with a spirometer, I can tell the tidal volume, I can tell the inspiratory reserve and the expiratory reserve. Tamam? So that is included in total ventilation and vital capacity. So all of these are out. Finally, we have respiratory frequency, and I just told you you have a stopwatch, so you can tell how frequently the patient is taking breaths, basically. And so the only thing that you cannot measure is the functional residual capacity, which is the volume left in the lung after the patient takes their breaths, right? Inhales and exhales. And so you cannot measure this with a simple spirometer or a stopwatch. Tamam? Okay, next question. A 34-year-old man is evaluated due to dyspnea. The patient undergoes a complete pulmonary function test as well as lung volume measurements. His pulmonary volume curve, which is the blue line, is compared to the normal one, which is the black line. Which of the following measures is increased in this patient? Notice here the y-axis is the lung volume, and the x-axis is the time. Okay, I'm seeing B. First of all, what does the patient have? What's the medical condition in this patient who has an increase in the volume of their lung? Oh, by the way, I don't know why this is supposed to be D. Sorry. This is supposed to be D, and this is supposed to be E. Obstructive disease, excellent. So what happens in obstructive disease is that you have a patient who has a lung that does not have as much elastic properties as it used to. Okay, so in this obstructive disease lung, the lung you can expand a lot. I can fill it with a lot of air. But since it lost its recoil properties, the lung doesn't have as much elastin to make it recoil. And so the expiration in this lung is difficult. Okay, the patient can inhale easily, but they can exhale with a lot of difficulty. And so the lung volume is increased. Tamam? Now, we know now that the patient has an obstructive disease. In an obstructive disease, what is increased? The residual volume, is it decreased or increased? Increased, right? Because we cannot remove it. And same for the total lung capacity. It's also increased. Tamam? What happens in here is that their expiration is difficult. Tamam? So one of you guys said B. if human this speed, تمام, their forced expiratory reserve volume, do you think this will increase or decrease if you have an obstructive disease and you are having difficulty with exhalation? Excellent. It will decrease, right? Since I'm having difficulty with removing removing oxygen from my lung, my forced expiratory reserve volume will decrease. So will my forced vital capacity, and so the ratio also will decrease. تمام? So this ratio is actually decreased in obstructive lung disease. Forced vital capacity, we said, decreases, and then you have the residual volume over total lung capacity ratio. This will, yes, it is E, this will increase. تمام? Since we have an increase in residual volume and an increase in total lung capacity, the ratio between them will increase in an obstructive lung disease. As you can see here, this is a very important slide. So here you can see that when you have obstructive lung disease, and you can easily fill up your lung, so you can take in a lot of inhalation with ease, but you cannot exhale as much as you can, the total lung capacity will increase, and the residual volume, the leftover volume after you have exhaled, will also be increased. And therefore, when you put these in a ratio, the ratio of the residual volume and total lung capacity will increase. But keep in mind, I don't have the slide here, I think, but keep in mind that the forced expiratory volume over forced vital capacity ratio is decreased, not increased, in obstructive lung disease. تمام? طب let me ask you guys. Forced expiratory reserve volume in 1 second over forced vital capacity ratio in restrictive diseases. What will it be? Will you find it to be normal, increased, decreased? Stays the same or increases? Excellent. It does not increase, it stays the same, or yes, it does increase, sorry. So basically in a restrictive disease, you have fibrosis, right? So the lung is hard, you cannot fill it with as much air as you can. So inhalation is the issue in a restrictive disease, which means that exhalation is not an issue, right? And so the forced expiratory reserve and forced vital capacity ratio will actually either be normal or it will be slightly high. Do you guys understand that question? Should we move on? Excellent. تمام. Okay, a 36-year-old woman presents with shortness of breath. She has a history of blood clots and is currently not taking any medication for prevention. If she has a pulmonary embolism, what is blocking the blood flow? Can you guys see the screen? One second. Can you see it now?
Yeah, we can see it now.
So, what do you think the answer is? Excellent, Hannah. The answer is D, increased alveolar dead space. What kind of dead space is this? Excellent. This is physiological dead space. So, what's happening to this patient is that she has these are normal lungs here, okay? And we said that in the okay, let's actually just go back here. تمام. So these are your lungs. And we said that the conducting airways are all part of the anatomical dead space. Why is it called dead space? Because no gas exchange occurs in these anatomical airways, tamam? These conducting airways. Meanwhile, in the respiratory airways where diffusion can occur, we don't have that space anymore. We have a working space where diffusion basically occurs. Now, what if I tell you that here there's a vessel, tamam, and it gives blood to keep the alveoli alive, but I block this vessel and no more blood flow can go in. This means that this part of my lung, or these alveoli, are dead. And so I can count them or add them to the anatomical dead space. Tamam? This is called now physiological dead space because it used to be a place where diffusion used to occur. Tamam? But after I blocked it and it died, it's no diffusion and no gas exchanges occurring here. So I count this as physiological dead space. So going back to the question, D is the correct answer. If you have pulmonary embolism, what will happen? You will have a decrease in ventricular preload since less blood is now going to the ventricle. If you have a decrease in ventricular preload and the heart senses this, it will increase its rate. So decreased heart rate should actually be increased. If you have part of your lung lost and no gas exchanges occurring there, then you will expect that you will hyperventilate, not hypoventilate, and therefore your respiratory rate will increase, not decrease. Does this make sense? Okay, tamam, let's move on. So, as a person takes a deep breath, the compliance of the respiratory system changes with lung volume. At which lung volume or capacity does the respiratory system have the greatest compliance? You're saying D, and I'm also seeing C, and I'm also seeing A. Tamam. Okay, let's explain each of these. First of all, the answer is, mashallah alayki batul, it's C. Why? A is the, so basically here, do I have it? No, I don't have it. Like, A is the total vital capacity, tamam? It's the normal breath that you take. And this is the tidal volume. B is the total vital capacity. Okay, this is the total lung volume here. C is after you've emptied your lung, normal exhale. Tamam? D is the residual volume. And E is 0. You don't have any volume in your lung. Pay attention to the lung volumes here. Tamam? And so the answer is C because this is the functional residual capacity. صح? And this is where the compliance is highest in the lung. It is not highest at A. At A, what? At A, this is around, for example, here, kind of, is where the chest has the highest compliance. Tamam? And B is just the total lung capacity. But the respiratory system has the highest compliance here at the functional residual capacity. Does this make sense? Tamam, excellent. So the next question says, pulmonary surfactant and what's true and what's false. So which of these is true? All of them are false except for one. Excellent. The answer is E. Why? Does pulmonary surfactant increase or decrease the surface tension? It decreases it, صح? So A is out. Let's use this one. Play. And what type of alveolar epithelial, what type of cells secrete surfactant? It's type 2, not 1, so B is out. And surfactant is made of lipids, not protein. And finally, it actually, since it decreases the surface tension, it decreases the work required to expand the lung, so D is out. Finally, you're left with E. It says, helps to prevent transudation of fluid from the capillaries into the alveolar space. Now, the surfactant is a layer that is lining the alveoli, right? This layer is lining the alveoli, and after that you have the capillaries. If you have surfactant, you're preventing the fluid in the capillaries from going there. So it helps to prevent the fluid from going in there and causing pulmonary edema. And here, this is the slide that tells you that it reduces surface tension, increases compliance, and therefore decreases the work the lung has to do, minimizes fluid accumulation, and it keeps alveolar size relatively uniform. Is this clear? Right. Next question. In which of these states is lung compliance increased? Excellent. MashaAllah, you guys are really smart. The answer is A, emphysema. So what is emphysema? What is it characterized as? Is it obstructive or is it a restrictive disease? Excellent. It is an obstructive disease. So here's the graph in your lecture, and it's showing you that compliance is the highest in obstructive diseases like emphysema and lowest in fibrosis. Why? Because we said that in obstructive lung disease, the elastic recoil of the lung is lost, but you can inhale very easily and exhale with difficulty. And so you have this sac that you can fill with a lot of fluid, but when you try to deflate the sac, it deflates at a very slow pace and with extreme difficulty. And so since I can fill it with so much oxygen, it is very compliant. Why is the normal lung not as compliant as the emphysematous lung? Because the normal lung still has the recoil force. Because if I fill the normal lung a lot, there comes a point where I cannot fill it anymore because it is opposing this filling of oxygen with its recoil force. And as for the fibrous lung, this lung is so hard. And when you have something that is so hard and stiff, I cannot fill it up with so much oxygen. And so it has the lowest compliance. Does that make sense? All good? Like, the next question. So here, you have respiratory physiologists conducting a study to assess airway resistance of the lower respiratory tract in healthy individuals. And during the experiment, they measured the total cross-sectional airflow resistance as it changes between each airway generation. Which of the following is most likely to be observed? So what is the normal airway resistance graph? Which of these is normal? So here you have on the y-axis, you have airway resistance, and on the x-axis, you have the different generations of airways. You are saying top left, which means you're saying this is the answer, right? So let's call this A, B, C, D, and E. So you're saying A is correct? Okay, you're all saying A, but you're wrong. The answer is actually D. Why is it D? Because notice here that we have three main generations mentioned. We have the trachea, which is the start of our airway, more or less, and then you have the medium-sized bronchi, and then you have the terminal bronchioles. Now, resistance is actually highest at the medium-sized bronchi rather than at the trachea. Here in A, they're telling you that the highest resistance is at the trachea, then it gets lower progressively. But that's not the case. The highest resistance is at the medium bronchi. And you can see that here at the segmented bronchi, you have the highest resistance because these guys, the segmented bronchi, have the lowest radius, okay? And so that is why they have the highest resistance, more than the trachea. And so the point of this question is to test you on the knowledge that the medium-sized bronchi are the ones with the highest resistance in the airway. Meanwhile, when you get to the terminal bronchi, the resistance is very low. Because here, when you get to the terminal bronchi, you have more cross-sectional area. Does that make sense? Excellent. Also, just notice in this graph, here it says resistance from mouth to the generations. Tamam? And you can see that the resistance in the mouth is pretty low, and then it gets higher. Let's say this is the trachea. And then here, when you get to the segmented bronchi, it is the highest. Right. Next question. A 66-year-old woman presents with a 9-month history of worsening dyspnea on exertion. Spirometry reveals an FEV1 that is significantly lower than predicted based on her age, height, and gender, and a lower than predicted FVC. A decreased ratio of FEV1 to FVC. So which of the following can explain these results? First of all, what is her medical condition? What do you think this patient has? Okay, yes, she does have an obstructive disease. I'm seeing B and E. So the correct answer is B, because we said that when we have an obstructive disease, we have decreased elastins in our lungs, which means a decreased elastic recoil. And so we said before that the obstructive diseased lung cannot exhale very well. And so the FEV1 and FEVC will be decreased, and the ratio will be decreased in these patients. Now you said E, thickening of the blood gas barrier. That is not true. Do you know why and where this happens? In which disease do you have thickening of the blood gas barrier? Excellent. When you have fibrosis. Edema could do that, yes. If you have edema, then you will have difficulty in gas exchange and the barrier will get thicker. But the one that is relevant to this is fibrosis or a restrictive lung disease. Excellent. So this is a very important slide that you guys need to pay attention to, specifically just this part, that the FEV1 FVC ratio is decreased in obstructive disease and normal to increased in restrictive diseases. Tamam? So you also need to pay attention to the fact that this ratio is the one that's decreased in obstructive. The one that is increased in obstructive is the residual volume over the TLC. Okay? So by here, it decreases because this is talking about the exhalation. Okay, here they're increased because we have more, the obstructed lung has more capacity to fill in air. So we have more residual volume and more TLC. Okay? Okay, excellent. Next question. You have a healthy 22-year-old college student participating in an experimental pulmonary function test. And this is, or his, sorry. Okay, so his flow volume loop is shown. Which point indicates total lung capacity? Again, notice here, there's the volume and there's the flow. Let's see, you're saying E, correct. So here, just notice on this graph that volume is basically the opposite of what you would expect. So the volume is highest here and the lowest here. And we know that the total lung capacity is when you have the most volume in the lung. So that would obviously be here, E, the highest point. Excellent. Okay, last question. Dilation of bronchial smooth muscles is mediated by action of which receptors? Can you tell us what the other points mean? Okay, before we go into this. So here, you have a pulmonary function test. Here we said this is the total lung capacity. This is expiration. And this is inspiration. When you inspire, you start with residual volume, right? And then you fill it up. And you're increasing the volume until you get to total lung capacity. After that, you're just exhaling. So here in A and B, they're just showing you that you are exhaling the air that you have in your lung. Okay? So the most important points for you are C and E. تمام؟ C is the residual volume. So basically, here is where you start off out when you first exhale. If you take a pulmonary function test, basically evaluates the patient's pulmonary function. So they tell the patient to do their maximal inhale and their maximal exhale. And so with the maximal inhale, you get the total lung capacity. And with the maximal exhale, you get the residual volume. And so you just need to know that this part is for expiration, this part is for inspiration. The starting point for the expiration is the residual volume, and the end point for inspiration is the total lung capacity. تمام؟ Excellent. طيب. Now for me, this is the last question. Dilatation or dilation of bronchial smooth muscles is mediated by activation of which of these receptors? I'm seeing A and D. And the answer is D. So the way I like to remember this is that basically what you have is beta 1 and beta 2. Beta 1 receptor, beta 1, where is it found? You guys should know this. Where are beta 1 receptors found? Like, they are found in the heart. So you have beta 1 receptors in the heart and beta 2 receptors in the lungs. And so this means, how I like to memorize this is that you have a single heart and you have two lungs. And so always remember that the beta 2 receptors are the ones that are in the lungs. Now, if you activate beta receptors, they're activated by sympathetic stimulation. And so what happens when you activate these receptors is that the smooth muscles in the lungs will dilate. They won't constrict, they will dilate. And so you can think of it like this. When you are running, you have sympathetic stimulation. And when you run, you're using all your muscles and you're breathing a lot more. So you need these muscles to be dilated so that you can inhale more oxygen. And so remember that beta 2 stimulation of the lungs equals to dilation, and this is sympathetic. Meanwhile, beta 1 receptors, they will just increase your heart rate. Now, as for alpha 1, one of you said alpha 1 receptors and alpha 2 receptors are not found in the lungs, nor are they found in the heart. These are related to the vasculature. And if I stimulate these guys, I will get vasoconstriction of the vessels. Nothing to do with the heart, nothing to do with the lung. Okay? And finally, M2 receptors, these are actually related to acetylcholine and so on, and these cause bronchoconstriction, not bronchodilation. Is that clear? That's it for this part of the PAL session. Next, the next parts of the pulmonary section will be by Sidrah. Are there any known other receptors we have to know? No, these are the main ones. And I forgot to include the slide, but this is mentioned in your lecture that beta 2 receptors, adrenergic receptors, are in the lungs. And just keep this in mind because you will revisit this concept again in basically the rest of medicine. So it's a very vital concept because it's related to the action of drugs and other kinds of concepts. So for now, you just need to know the beta 1, beta 2 receptors. Beta 1 are in the heart, beta 2 are in the lungs. The alpha receptors, you don't really need to know them for this block, nor do you need to know the M2 receptors for now. Anytime, you're welcome. Allah يوفقكم ويفتح عليكم. Inshallah, it will be a very, very easy exam. So for me, this is it. Now Sidrah will take over.
Thank you so much, Tasneem. It was such a nice session.
Thank you. Inshallah, yours goes well now.
Inshallah. All right. So I'm gonna finish off the rest and we'll start. Inshallah, we'll try to finish this as fast as possible because I heard you have a session at 5, so inshallah we'll get this done. All right, so the next question is from lecture 22, and it's a question where we have to start calculating things. So a person with normal lungs at sea level, 760 millimeters mercury, is breathing 50% oxygen. What is the approximate alveolar PO2? I'll give you some time to calculate, and then I will let you know the answer. All right, someone said C. Okay, well, if there are no other answers, then I'll show you the actual answer, which is C. And you're correct, it is C. So how would we calculate this? Okay, so in this situation, what we have, what is given is the sea level. So we call this the barometric pressure, so PB. But we're also given 50% O2, which is the fraction of O2 in the atmosphere. And so what they want us to know is find the alveolar PO2. So we have to use two types of equations here. First, in order to find the alveolar PO2, we need to know the um, inspired PO2. So the inspired PO2 minus the PCO2 over R. To the R. So this is the first equation in order to find the alveolar PO2. But we also don't know what the inspired PO2 is. And so we use another equation. The inspired PO2 is equal to the fraction of oxygen, of inspired oxygen, times the barometric pressure minus the pressure of water. Now, there are some values that you have to remember. So we have to remember that R equals 0.8. And that H2O is equal to 47. And so after that, we just plug in the numbers. So we plug in this equation first, we plug in 50% or 0.5 times 760 minus 47. And what we would get for inspired PO2 is 356. Okay? Then we take this value, 356, and plug it back into this. So let me use a different color here. Use 356 for here. And then the PCO2, oh, here's another value that you have to know. Usually the PCO2 is 40, unless they mention something else, unless they say, oh, by the way, the PCO2 is 30 or something. Usually it's 40 millimeters mercury. So we know PCO2 is 40, and we know the ratio is 0.8, and we calculated the inspired O2. So you basically just subtract 356 minus 40 over 0.8, and this will give you a alveolar PO2 pressure of oxygen of 306. I hope that is clear. And does anybody have any questions? I guess not. So anyway, here in the next slide, you can see the calculations, and if you ever want to review it, it's here. The next question is asking, a person's normal VT is 400 milliliters with a dead space of 100 milliliters. The respiratory rate is 12 breaths per minute. The person undergoes ventilation during surgery and the VT is 700 with a rate of 12. What is the approximate alveolar PCO2 for this person? All right, so if there are no answers, does anybody want to answer? All right, then I'll just tell you the answer. So the answer is 20. And the way you would do this is you need an equation. So the equation here is that in order to figure out what the alveolar ventilation is, you will use a formula where you say the total ventilation minus the ventilation of the dead space times the frequency is equal to alveolar ventilation. Now, in this case, though, we find that the frequency is the same in both scenarios. So we're just going to ignore the frequency for now. We're going to say that the alveolar ventilation is equal to the total ventilation minus the dead space ventilation. And in this case, the first case, we see, let's say scenario number 1, we say that the VT is 400. This is the VT, minus the dead space ventilation, which is 100. So 100 is the VD. So the total, so VA should equal 300. And then in the second scenario, what happened was the total ventilation is 700. And we can assume that the dead space is going to stay the same, so it's 100, which equals 600. So the total ventilation in the beginning was 300, and then after, when the person was under stress due to surgery and they're undergoing ventilation, their alveolar ventilation doubled. So when alveolar ventilation doubles, you see a half decrease in the amount of partial pressure of CO2. And that's because the more ventilation you have, the more expiration of CO2 you do, and you have less CO2 in your alveoli. And so with that logic, we can say that the usual alveolar PCO2, which I told you is always 40 mmHg unless told otherwise, now becomes 20 when there is a double increase in the ventilation. Okay, moving on to the next question. That's also, this slide is, okay, this slide is really important because it has a lot of formulas that you need to know for these questions, and just try to memorize these formulas and practice with them in order to remember these. Moving on to the next question. At a fraternity party, a 17-year-old male places a paper bag over his mouth and breathes in and out of the bag. As he continues to breathe into this bag, his rate of breathing continues to increase. Which of the following is responsible for the increased ventilation? All right, yes, you're right. It is B. And why is that? Because this person he had a bag over his mouth, right? And when he was breathing in and out, he's basically breathing out in the same air that he was breathing out. So if you breathe out CO2, he's taking in more CO2. And when he's taking in more CO2, there's an increase in alveolar CO2. And we talked about how if there's a double increase in ventilation, there's a half decrease in PCO2. So in this scenario, it's basically reversed. If there's an increase in PCO2, naturally the ventilation should increase to try to compensate for the increased PCO2. We're trying to exhale more PCO2. All right, moving on to the next question. What is one factor that decreases the diffusion capacity? Yes, you're right. A, which is pulmonary fibrosis. And in one of the questions that Tasneem explained, she said that pulmonary fibrosis causes thickening of the diffusion membrane or the barrier between the blood and the alveoli. And that's what causes a decrease in the diffusion capacity because it's harder for oxygen to diffuse across the membrane if it's thicker. There are a few things that I want to show you. So this is basically the diffusion limitation of a gas, that's DL, and there are different factors that affect the diffusion of the gas across the membrane. So P1 minus P2, this explains the driving force of a gas. And in terms of the diffusion limitation, there is D, which stands for the diffusion coefficient, which is it's a factor that never changes. It's like a common number. The alpha stands for the solubility of the diffusing gas. A stands for the surface area, and the T is for the thickness. And notice that it's in a fraction. So if thickness increases, then the diffusion capacity should decrease. Going on to the next question, a child who is eating round candies approximately 1 and 1.5 centimeters in diameter inhales one down his airway, blocking his left bronchiole. Which of the following describes the changes that occur? Yes, you're right. It is E. Um, so why is that? So basically, when he has a blockage of his bronchiole, that basically means he's not able to inhale fresh air from the environment. So what's left is in his alveoli, he should have an increase in PCO2 because there's less oxygen, there's no PCO2 coming from the blood. And also the alveolar PO2 should decrease because there's no air that's being inhaled or no fresh air being inhaled. Similarly, the systemic arterial PO2 should also decrease because if there's no O2 or there's decreased O2 in the alveoli, then naturally less O2 is diffusing into the arteries, which is why the systemic arterial PO2 is also decreased. Moving on, what is the proper order for the pressure in the middle part of the lung, zone 2? This part is a little tricky because there's just so much, but hopefully you guys can get it. Okay, I got one answer, A. There's a C. All right, so the first thing is the answer is A, but I'll explain why it's not C. So let's look at this diagram first, and it was in your lecture. So in the top portion of their lung at zone 1, the thing is because of gravity, there's less blood flow in the area. So naturally, pressure in the alveoli should be greater than the arterial pressure and the venous pressure, because if there's less blood flow going, then there's mostly the alveoli that's there, and the alveoli has more pressure. Then when you go into zone 2, there is more arterial pressure than there is alveolar pressure. And something I want you to remember here is that in zone 2 and zone 3, you notice that the first value is PPA and PPA, right? And this stands for the arterial pressure. Notice how the PPV, or the venous pressure, is like variable. It starts from it's at the very end, and then it's in the second space. If you ever have a question like this, and when you have multiple choices, like in the previous, you have multiple choices, PPV should never be in the first place, because arterial pressure is always greater than venous pressure. So any choices like C and D are never the case, because, like I said, arterial pressure is greater than venous pressure. So that leads us to either arterial pressure, alveolar pressure, and then there are different combinations. But since we're talking about zone 2, there is perfusion from the arteries. So the arterial pressure is the greatest. And then the next thing would be the alveolar pressure, because again, gravity and things like that. And then lastly, we'd have venous pressure. Whereas when you're in zone 3, the gravity pulls all the blood down to the lower parts of the lung. So it would be arterial pressure, then venous pressure, then alveolar pressure. Does that make sense? All right, that's great. Okay, moving on to the next question. A 32-year-old man drives to the top of Pikes Peak, where the oxygen tension is 85 millimeters mercury. Which of the following best describes the effects of hypoxic environment on the pulmonary and systemic vascular resistances? Okay. All right, so I got B as an answer. And unfortunately, that's incorrect, because the correct answer is D. But I'll explain why it's not B. So when someone is in a hypoxic environment, in their lungs, there are areas that have less oxygen. And what we learned in physiology was that in the lungs, if there's less areas of oxygen, there is vasoconstriction in that area, because there's no use in providing blood flow to the area if there's no oxygen for diffusion. So instead, the blood supply goes to areas where there's more oxygen, and there's more vasodilation in the areas where there's more oxygen, so that oxygen can diffuse into the blood supply. So with that logic, if the lungs are in a hypoxic environment and there is less oxygen in the lungs, then naturally there would be constriction of the vessels, and constriction would lead to increase in resistance. So the pulmonary vascular resistance would increase. And with that, we can take out this option, this option, this option, and these. So we're in between three options, D, E, and F. Now, when there is a hypoxic environment, and you're again, we talked about how there's constriction in the pulmonary vessels, but in the systemic circulation, it's basically an opposite effect of the pulmonary circulation. What the systemic circulation does is it tries to dilate as much as possible so that it can increase the blood flow to organs in order to transport oxygen to these organs from metabolic activities. So naturally, it would cause vasodilation in the systemic vasculature, and therefore there would be a decrease in resistance. So the answer here would be an increase in pulmonary vascular resistance due to constriction, and a decrease in systemic vascular resistance due to vasodilation. Okay, so why was pulmonary resistance increased? Because we said there's constriction. If there's constriction, there's more resistance. So constriction causes resistance. That's why pulmonary resistance increases. And like I mentioned, the constriction was because you don't want blood to go to an area that has no oxygen. You want your blood to go to an area where there is oxygen so it can diffuse. And then you can collect as much oxygen it is to like send it to your organs. Does that make sense? Doesn't increase oxygen, increase sympathetic, so basic. This, okay, so decreased oxygen, increasing sympathetic, causing vasoconstriction is something that happens after. This, here you would say, this answer choice is the initial response. Initially, if you're in a hypoxic environment, you would have vasoconstriction, and then in the pulmonary, and then systemic is vasodilation. But over time, because your respiratory centers will understand that there's a decrease in oxygen, then the sympathetic system starts to kick in, but it's more delayed. This is what we're asking here in this question is what is the initial response? I hope that makes sense. All right. Okay. I'm going to move on to the next question. Woo. Okay. There. All right. So in the transport of CO2 from the tissues to the lung, which of the following occurs in venous blood? Yes, you guys are right. It is A, the conversion of CO2 and water to hydrogen ions and bicarbonate by carbonic anhydrase. And this occurs in the red blood cells. The reason why like the other options are incorrect, like for example, in B, you would say it's incorrect because it happens for oxygen and not necessarily carbon dioxide. For C, there is the chloride shift, which of course helps for shifting bicarbonate into plasma, but this is a secondary mechanism. What's important in this question is the main mechanism for carbon dioxide transport is through bicarb conversion. So you can see it in this diagram. You see most of the carbon dioxide gets converted into bicarbonate in the erythrocyte. Okay, moving on to the next one. A 16-year-old male is rushed to the emergency department following a heroin overdose. Physical exam reveals a respiratory rate of 9 breaths per minute, blood pressure of 98/62 millimeters mercury, and an irregular pulse. He is afebrile. Which of the following oxygen hemoglobin dissociation curves is predicted for this patient? Okay, so someone said 2, which is B. Okay, and someone said D. And yes, D is the correct answer. So let me explain. So in this curve, the normal curve of any regular person that's perfectly fine is 3. Okay? Oh, 3. Um, and in this case, someone is taking heroin, which is a drug. And what that does is it causes a depression of the respiratory center, and this leads to hypoventilation. So if someone is hypoventilating, okay, they have an increase in PCO2, and they also have a resultant increase in hydrogen ions, which lead to a decrease in pH. And this is the oxygen hemoglobin dissociation curve, right? So when you think about the different shifts from this is the normal, by the way, normal, and this 4 is the right answer. This is a right shift. Right shift indicates that there is a less affinity of oxygen to hemoglobin. And this is done because carbon dioxide and hydrogen ions both bind to hemoglobin, which leads to decrease of oxygen binding to hemoglobin. And because of that, we have a right shift of the curve, which is curve 4. The reason why it's not 2 or 1 is because this is a left shift, which indicates that there is an increase in affinity of oxygen to hemoglobin, which is not the case because we have an increase in PCO2 and hydrogen ions. Is that clear? Great. Okay, moving on to the next one. Oh, this is same thing that I explained, and these are some things that would cause a right shift. The hydrogen concentration, CO2, an increase in temperature causes the right shift, and also that 2,3 BPG concentration. Moving on, which of the above oxygen hemoglobin dissociation curves corresponds to blood during resting conditions, which is the red line, and blood during exercise, which is the green line? Great, guys, you got this. It is B. And the reason why we said is because of the exercise. So when you have exercise, you're increasing the amount of CO2 that's released. You're also increasing the amount of hydrogen concentration and hydrogen ion concentration. And also by exercising, you're increasing temperature. And like I mentioned in this previous thing, increase in CO2, increase in hydrogen ion concentration, and increase in temperature causes a right shift. And that's what's seen in B. So great job, guys. Okay, next question. Ooh, this one has calculation. A 55-year-old female passenger on a commercial airline flight is experiencing severe dyspnea. On questioning, she reports a history of deep vein thrombosis. The plane makes an emergency landing and the passenger is taken to the nearest emergency department by ambulance. Arterial blood gas, ABG labs on room air are as follows. PaO2 or arterial PaO2 is 72 mercury. PaCO2, arterial CO2 is 30 millimeters mercury. Inspired O2 is 150 millimeters mercury. The pH is 7.49. Respiratory exchange ratio is 0.8. What is the patient's A difference? Great. Great, good job, guys. Yes, it is C. And how would we calculate this? Well, we know that we have let me just take this. Okay, so we have the PaO2, and all we need to do now is to calculate the P alveolar O2, which again, like I mentioned in the previous, we just have to find this using the inspired O2. So PiO2 equal minus the PaCO2 over 0.8, which was the respiratory quotient, which we mentioned here. So and then this is 30 and this is 150. So this equals 112.5. And then you just do 112.5 minus 72, which equals 40.5, which is the correct answer. And here is the calculation in case you want to refer to it. Okay, moving on. A 62-year-old man at sea level breathes a gas mixture containing 21% oxygen. He has the following arterial blood gas values. PaO2 is 60 millimeters mercury. PaCO2 is 70 millimeters mercury. Which of the following is the cause of his hypoxemia? Okay. All right, so we got mixed answers on this. We got A and D. And the correct answer is A. Now, first of all, what we need to do for this is we need to calculate the AA difference, the alveolar arterial difference. So here we have the PaO2. We need to find the PaCO2. I'm gonna skip all that math things and just tell you that the PaO2 is equal to let me see, 63. It was 63. If you do all the math, and because we're short on time, I can't really go into the math. But anyway, it's 63. And we know that the PaO2 is 60. So when you do a calculation, you do 63 minus 60, which gives you 3 millimeters mercury, which is in the normal range of the AA gradient. So we're saying that the AA gradient is normal. Now, in these cases, hypoventilation is the only case in which the AA gradient is normal. And that's because when you have, for example, fibrosis, you would have a decrease in diffusion across. So the arterial oxygen pressure would be decreased, and therefore the AA gradient would be decreased. For VQ defect, which is basically the ventilation perfusion, if there's a defect in that, you also have a decrease in arterial oxygen. So here we had a decrease in O2, which causes a AA increase. And then here also we had a decrease in PaO2, which causes an AA increase. A right to left shunt would also cause an AA increase because there's a decrease in PaO2. So we have normal alveolar oxygen, right? But PaCO2 increase with the shunt. Yes, but in this case, we're talking about our arterial oxygen. So with a right to left shunt, we are basically shunting deoxygenated blood from like the right side of the heart to the left side of the heart. So the blood that's going to your arteries and to your tissues has lower oxygen concentration as compared to the oxygen concentration in the alveoli. And that's why the AA gradient would be increased. And in the case of anemia, this wouldn't necessarily cause an issue. It would have something to do between basically the attachment of oxygen to hemoglobin. So the answer here is hypoventilation. All right, I'm going to the next question. I hope that made sense. Okay, which of the following causes of hypoxia is characterized by a decreased arterial PO2 and an increased AA gradient? Yes, in this case, you are correct. It is B, because of the deoxygenation of the blood in the arterial system. So the other reasons why, like for example, hypoventilation is incorrect is because in the previous case, we figured out that with hypoventilation, we have a normal AA gradient. Same thing with right and left cardiac shunt, we found out that the AA gradient is increased. With anemia, the AA gradient is relatively normal because of the decrease in binding to hemoglobin and not because of the decrease in diffusion. Same thing with carbon monoxide poisoning. It's because of the affinity of oxygen to hemoglobin, not necessarily the gas exchange. And lastly, if there's an ascent to high altitude, because you're decreasing how much oxygen you're taking in, both the alveolar oxygen and the arterial oxygen would be decreased to the normal amount, so you technically have a normal AA gradient. I hope that makes sense. And moving on to the next question. If the ventilation perfusion ratio of a lung unit is decreased by partial bronchial obstruction while the rest of the lung is unaltered, the affected unit will show. All right, I got E. D. All right, so the correct answer here is E. And this is because when we have a obstruction of the lung, right, we have the first answer is increased alveolar PO2. That's naturally wrong because if you have an obstruction of the lung, you're naturally not able to inspire more air. So alveolar PO2 would decrease. B says there's a decreased alveolar PuCO2. Again, that's wrong. If there is obstruction of the bronchiole, basically you would have an increase in PCO2, alveolar PCO2. C, no change in alveolar pressure of nitrogen. That's not true because if there is less oxygen, when you inspire air, there's always nitrogen in the air, so we're always inspiring nitrogen. If there's decreased oxygen, like the partial pressure of oxygen, then there's less dilution of the nitrogen, so naturally the pressure of nitrogen would increase. But of course, this isn't really important for our block. D, a rise in pH of end capillary blood. There would actually be a reduction in pH of the end capillary blood because of the increased PCO2 that's coming out from the tissues. So because there's more carbon dioxide that's coming from tissue metabolism into the capillary, at the end of the capillary, because there is CO2, it causes a decrease in the pH because of the increase in hydrogen ions. You have to remember that CO2 causes an increase in hydrogen ions, and if there's more hydrogen, there is a decrease in pH. So I hope that makes sense. All right, that's great. Moving on to the next question. Okay, great. We're on to the last part. This is the second to last question. So, concerning the central chemoreceptors, what is the answer choice? Okay, we got a C. All right, so C is correct. They are activated by changes in the pH of the surrounding extracellular fluid. So an important thing about central chemoreceptors is that they respond to changes in uh, the pH. And if there is any change in, for example, PCO2, because like I said, like I mentioned before, carbon dioxide increases hydrogen ions, which causes decrease in pH, they would be activated. It's important to remember, though, that central chemoreceptors do not respond to oxygen. They specifically respond to pH differences. That makes me have to ask you another question, which is, what is a stimuli for the peripheral chemoreceptors? Okay, so, okay, yes, O2 is the, okay, oh, I'm so confused. No. Someone asked, do they respond to CO2 or pH? I think you're referring to the central chemoreceptors. The central chemoreceptors, um, they respond to changes in hydrogen concentration or hydrogen ion numbers and they're inactivated by cold and anesthetic. So basically, an increase in PCO2 would have an indirect effect on the hydrogen ions, which would then increase the pH, right? So you could say indirectly PCO2 affects the central chemoreceptors, but the main thing is that the central chemoreceptors respond directly to changes in the pH. And in terms of the peripheral chemoreceptors, a question that I mentioned earlier, the peripheral chemoreceptors respond specifically to changes in O2 and like hypoxia. So the difference between the two, central chemoreceptors respond specifically to changes in pH, which can be indirectly altered by PCO2. And peripheral chemoreceptors respond to changes in oxygen, like in hypoxia. All right, does that make sense? All right, great. Last question. Woohoo! The basic rhythm of respiration is generated by neurons located in the medulla. Which of the following limits the duration of inspiration and increases respiratory rate? Okay, we got D. Great, you guys are correct. It is D. And just I'll quickly go over the other ones. So the apneustic center, this one I do not think was mentioned in your lecture, but basically it's located in the pons and it promotes inspiration and also prolongs it, which is why it's not the correct answer choice. For B, which is the dorsal respiratory group, which is also known as DRG, what it does is it generates the rhythm for respiration. So it does not limit the duration and it does not increase the respiratory rate. It just regulates the rhythm. C, which is the nucleus attractus solitarius, NTS, it basically gets sensory information from the vagus nerve, like baroreceptors and chemoreceptors, and it's not directly involved with limiting the duration of inspiration or increasing the respiratory rate. And lastly, E, the ventral respiratory group, is responsible for both inspiration and expiration, so it's not specific. Only D, the pneumotaxic center, is specific for limiting the duration of inspiration, which essentially leads to an increase in the respiratory rate. And this is basically a slide that goes over the different types. And lastly, my favorite slide, we're done. Alhamdulillah. All right, thank you guys for this session. If you had any questions or anything, let me know. You can text me on this number that I'm going to put into the group chat. Or sorry, in the chat. You can text me on that number. Oh, shoot. My bad. Here you go. That's my number if you ever want to text me. And there's the QR code here. If you have any feedback for this session, please, you can scan the QR code and fill in your feedback. We'd really appreciate it. And thank you guys for staying here for the whole session. I know it's been really long and I really appreciate your attention and your responses. It was really nice. You're welcome. Thank you guys so much.